loops. So the knowledge of anatomy is very important when we are dissecting. Magnification will definitely help in identification and closer dissection of the nerves and identification of the branches. But you have to be very, you have to continuously dissect using the loops. That should not be the first time we are using the loops and starting the dissection.
Will come down to us to see parotidectomy via microscope because they have seen Dr. Speaks and other people operating. The third is, if you are using it regularly with the microscope or loop, then it's okay. Otherwise, you should have a learning curve. Everyone has a learning curve to use it. Always loop, microscope, always better if you have them.
I agree with Bikram that if you are used to using the loops, I think a magnification will help you to dissect out the smaller branches and you will damage less. And it is just an adjunct which can be used when you are doing a dissection. But again, as Asim said, that you have to have a good technique, the surgical landmarks, all these things has to be used judiciously and so that you know the nerves. Any other, did you put the drain, Asim, for this patient? What did you do for this patient? What is your opinion about putting a drain, no drain?
So if you're doing a superficial parotidectomy, we always put in at least a 12-number drain when we are not doing a neck dissection. In this particular case, we had done a total parotidectomy, a neck dissection, and a transparotid excision of the ITF mass. So we had put in a drain. But specifically in a superficial parotidectomy, we always put in a drain.
Suppose this would have been an intermediate grade mucoepidermal carcinoma, which is the most common kind of histology what we get it in a parotid surgery. So what will be your approach for doing a neck dissection for these patients? How you will proceed?
So first thing, usually what we practice in our center is that we do a total parotidectomy for such cases, and we do a level 2 neck dissection and send it for frozen section. If the level 2 nodes are negative on frozen, then we do not go ahead with a further neck dissection.
Do you agree, Bikram? He wanted to do a total parotidectomy for an intermediate grade mucoepidermal carcinoma. Do you do a total only, or you will prefer doing only superficial?
Any size criteria you have seen for total parotidectomy in mucoepidermal?
So I will always consider doing a total parotidectomy in anything which is not low-grade mucoepidermal carcinoma. And even in low-grade mucoepidermal carcinoma, if there is clinically node positive or presence of positive nodes, I'll do a total parotidectomy and a neck dissection.
That you will have only on histopath, no? If either it is a low-grade or intermediate grade, it will come on histopath only.
No, so we send it for frozen section. We send it for frozen section. We have the advantage of sending it for frozen section and getting the histological diagnosis confirmation with us.
So for my thing means if I have to make a decision about whether to do a total or superficial, it will depend on few factors. Radiologically, if it's only in the superficial lobe, maybe in an intermediate grade, if I get a report and if it is a small tumor, then I will consider this patient for only superficial parotidectomy. But if radiologically it is going into the deeper lobe and it has got some high grade features, or in that situation a patient now preserving easily doable, then only total will be done for this patient. And a high grade, surely I will do a total parotidectomy. There is no doubt about that. So, and the neck node, what we were discussing, that we will send a level 2 for the frozen section and we will do a sampling. Any other? So
I'll just add one point to that, ma'am. So what we do, we study the scans very carefully, and even in whenever and look for the presence of intraparotid nodes. And if there is any presence of intraparotid nodes, even in a low grade or a intermediate grade mucoepidermal carcinoma, we always consider doing a total parotidectomy. even if it's a small 1 or 2 centimeter, but with presence of intraparotid node, it makes it a very high risk. So it should be that whenever there is presence of such nodes or any clinical nodes that are positive, then we consider doing a total parotidectomy plus or with or without a neck dissection.
There is a question. Bikram.
Parotid node, or if you are planning surgery for a parotid in case of metastasis from the other organs, even if there's small metastasis, still we always go with the total parotidectomy only, because there are chances that there may be small intraparotid nodes which you have missed clinically.
So there is a question. I agree with you that if the patient has got a metastatic squamous cell or kind of a adenocarcinoma or a scalp metastasis or a eyelid tumors, in that situation it is an aggressive tumor and maybe you will require a total parotidectomy. There is a question, what you do to prevent a Frey syndrome in your practice?
So the dissection is very important, that whenever we are raising the flap, so we have to raise a thick flap with the fat above and fat below. So we can always consider whenever you are using that, the above fat should not be very thinned out. So identify your smash layer carefully and then do the dissection anteriorly.
Do you put any thoughts about putting any interposition grafts or anything in between so as to avoid it?
So there is a lot of literature on that, but we have not. I have never used it, so I'm not very sure about it. And another practice that we sometimes do is when we are doing a small superficial parotidectomy and it's a clean field, then I would always not use any drain in such cases. So what happens is the collection of the fluid in between the parotid tissue and the skin flap. So that acts as a barrier during the healing, and that may prevent development of the Frey syndrome. But still in practice, we get upwards of 50% patients with symptoms of Frey syndrome in parotidectomy cases.
Do you use a parotidectomy classification by European committee that gives you levels? Do you use that? What is your opinion about using that classification? Bikram, you can also chip in any thoughts about that.
No, ma'am. Ma'am, please.
Okay.
Go.
So there is a European Salivary Gland Society classification where they have actually, we are doing parotidectomy. Everybody is doing parotidectomy. When you retrospectively evaluate, you really don't know which part of the parotid gland the tumor was. So there are level 1, 2, 3, 4, and the 5. 5 is for the accessory nodules, and 1 is for the superficial upper quadrant, basically above the main trunk. Then the lower is the 2, and then the 3 is the deeper portion, and the 4 is again the deeper and the superior one. So, and the accessory is the 5, and anything you remove on top of it, this is the extended kind of. It's a good classification to use it by everyone, just to document what part of the parotid you have removed when you are doing a surgery, a partial parotidectomies, and to nomenclate it better so that you can assess your results in a retrospective fashion, or even a prospectively, it will help you out what exactly your results. So we can compare our result very well. I think it's a good one.
There is a comment, I think.
Hello, sir. Sir, we are running short, half an hour late, sir.
Yeah.
We need to conclude this session, sir. Thank you, Dr. Asim Mishra, sir, for such a wonderful presentation. And I thank our expert, Dr. Anuja Deshmukh, ma'am, and Bikramjit, sir, for their surgical tips and tricks. Now we will move for the next session.
Thank you very much, Asim. Thank you, Bikramjit. Thanks.
Thank you.
The next session is panel discussion, approaches to cases of parotid tumor. The moderator for this session are Dr. Anil K. Dikrus, sir. He is Director, Oncology, Apollo Hospital, President UICC, Geneva, ex-Director and Chief Head and Neck Service, Tata Memorial Hospital, Mumbai. Dr. Sudhir Nair sir, he is Professor, Head and Neck Surgical Oncology, OIC, Surgical Oncology at TRAC, Tata Memorial Center, Mumbai. Dr. Manu Malhotra sir, he is Professor, Otorhinolaryngology and Head and Neck Surgery, AIMS, Rishikesh. Dr. Neha Mittal, she is Professor, Department of Pathology, Tata Memorial Hospital, Mumbai. Dr. Shwetabh Sinha, he is Assistant Professor, Radiation Oncology, Tata Memorial Hospital, Mumbai. Dr. Gopal Iyer, he is Head and Senior Consultant, Department of Head and Neck Surgery, National Cancer Center, Singapore. This session is moderated by Dr. Shiva Kumar Tyagarajan. He is Assistant Professor, Associate Professor, Head and Neck Surgical Oncology, Tata Memorial Hospital, Mumbai. I would request Shiva sir to please share his screen.
Yeah, thank you. I should do that. You probably should allow me to share the screen. At present, is showing that I will not be able to. You cannot share screen at present.
You can share the screen, sir.
Thank you. Yeah. Good morning to all. Am I audible?
Audible.
Yeah. Right. So at the outset, I'd like to thank the organizing committee for giving me this opportunity. And so this panel will essentially be discussing on approaches to management of the parotid tumor. So we have our esteemed panelist has already been listed out. So since this being essentially a postgraduate teaching sort of a session, so I just stuck to the basics more or less and straightforward clinical scenarios that we would come up with in our routine clinical practice. We have 50 minutes time to deal with them. We have 6 cases. Hopefully, we should be able to complete them. So just before going with the case discussion, just a brief introduction. So salivary gland neoplasms, we all know, are extremely heterogeneous group of tumors with many different biological and clinical behaviors. And every few months or often we do get a newer classification of a different type of salivary gland neoplasm that keeps getting added to the already huge list of salivary gland neoplasms. And it's sort of a less common variety of head neck cancers, contributing to 3 to 6% of head neck cancers world over. Parotid tumors are far more common among the various major and the minor salivary glands put together. So just to, just for the postgraduates to understand it more clearly, for every 100 parotid tumors, you would have 10, the numbers, for 100 parotid tumors, you would have 10 submandibular and 1 probably sublingual gland tumor. And the minor salivary gland tumors can arise anywhere from the oral cavity, pharynx, or in the parapharyngeal space as well. So, the history and physical examination, just for the benefit of the, postgraduates, I just would like to open this up to the panelists as well. Would the location of the tumor, the symptoms and examination give you an idea as to whether we're dealing with benign or malignant tumors? So we do have surgeons, pathologists, and radiation oncologists. So I'd like to first direct this question to the surgeons. Dr. Manu, would you want to take this up? Dr. Manu Malhotra, would you want to take this question? Hello.
Yes, Dr. Shiv.
Yeah, please. So in the during the history or the physical examination, history taking, how much of importance would you give for the location of the tumor or the symptoms or the examination findings, and how would it help you in assessing as to whether it's a benign or a malignant tumor that you're dealing with?
Yeah, definitely. I'll say that majority of the parotid gland tumors, they might be asymptomatic. And usually they're present in some preauricular and infraauricular region. And we must note that majority of them, 80 to 90%, I suppose, they are lateral to the 7th cranial nerve. But then we should be suspicious when there is a report of a rapid increase in size. And as you said, in history, there is pain and fixity to skin and presence of cervical lymph nodes. And of course, facial nerve dysfunction should raise the suspicion. So whenever these things are present, they should increase our suspicion towards the malignancy.
Right. Great points, though. So
diffuse swelling and greater than 4 centimeters are themselves the marker of high risk of malignancy.
Great points made there, Dr. Manu. So just to summarize the location. So the most common tumors, salivary gland tumors that we encounter are from the parotid gland, and in the parotid gland, around the majority are benign, and you have about 20% of them being malignant. And the tumors arising from the submandibular gland have 50% chance of either being benign or malignant. And the sublingual and the minor salivary glands are predominantly malignant. So the symptoms and the examination findings, Dr. Manu has already explained. One thing is that when you have a salivary gland swelling, in addition to what Dr. Manu has already mentioned, is that we should also not forget to examine the scalp as well. So or the eyelid for that matter. Eyelid would be obvious on examination, but at least the scalp, we could miss out on a possible primary. So to complete the examination while you're doing an examination of the salivary gland swelling, especially the parotid, it would be ideal to also examine the scalp as well. Any known risk factors? Overall, the risk factors remains largely unknown. There are various things that have been associated with the salivary gland tumors. Tobacco usage with most of the cancers, yes, and there's more association of use of tobacco and the Warthin's tumor as in the literature, and history of exposure to ionizing radiation and the ultraviolet radiation have already been mentioned. But by and large, salivary gland tumors, the etiology sort of remains unknown. So most of the discussion on the guidelines that are based on in this particular session is based on the ASCO guidelines, which came up the previous year, just for the postgraduates to go back to and refer. And these are helpful guidelines which you can just go back, and it deals with various aspects of the management of salivary gland malignancy per se. But you can also have a fair bit of idea as to in general how to go about handling salivary gland neoplasms. So coming down to the case per se, for the panel, we have this case. This is a 40-year-old lady who presented with swelling of 4 months duration with no comorbidities or no other symptoms. It's just the swelling. And we have another case, this lady present both in their 4th decade of life. One had a 4-month swelling duration, the other had 10 months. And the patient in the represented in case 2 had history of chronic renal disease with no other symptoms essentially. So the next question to the panel would be as to how would we go about evaluating this patient. So let's start with the imaging. So I'll just put this question across to Dr. Sudhir Nair. So sir, Dr. Sudhir Nair, imaging, what would you prefer? Ultrasound, CT scan, MRI?
Yeah. So as usual, I think we should complete the full clinical examination and see the history very properly, understand whether there is facial nerve involvement or not. So this will give an idea regarding whether the nature of the disease, short duration, facial nerve involvement, skin involvement, it can be a malignant disease. So with this clinical perception, then we will proceed with the imaging. As usual, we need a histological diagnosis plus imaging modality. An imaging modality we prefer to identify the extent of the disease, so that in case of a surgical procedure when you are planning, it will help us in designing the surgery and by understanding the true extent of the disease. Now, in case of histological diagnosis, an ultrasound guided FNAC or a fine needle aspiration biopsy will be a better option. And for imaging modality, I will prefer an MRI as the initial modality for a parotid lesion. So these are the 2 things we will do to further confirm my clinical suspicion.
Right. D'Cruz, Your take on this, sir, for imaging?
I'm sorry, Shiva, I lost the link in between, so I came back again in these two cases. So
yes.
I'll just build on what Sudhir. I listened to Sudhir.
Yeah.
By and large, the investigation of choice for salivary neoplasms is an MRI. You can get away with the CT in certain cases, but then when you look at the most contentious issues when you treat salivary glands, such as the facial nerve, whether it's going up into the skull base, whether it's going into the deep lobe, everything is better. Recurrent tumors, it's always better with MRI. So for the postgraduates, it's MRI, the investigation of choice.
Right.
You could do a CT in small cases, and if you don't have an MR, but you put up the ultrasound, and I love the ultrasound not to guide the FNAC, but just as a screening tool to distinguish between a parotid and an extraparotid, or a salivary and an extrasalivary tumor. So if I have something sitting at the tail of the parotid, I'll put the ultrasound. They might just tell me it's an innocuous node and the parotid is normal, and that's my screening investigation.
Right. Yes, sir. Great points. Those just for the postgraduates. So as already mentioned, the ultrasound may be an initial investigation, like what Dekru sir mentioned, to differentiate between salivary and extrasalivary tumors. And in if we are dealing with pediatric lesions, it could be any venous malformation, or arteriovenous malformation, something of that. So just to rule out as to what that lesion is. And it can also, you can do a guided FNA if required. It's easily available. That's the advantage of it. But however, it's operator dependent. You will not be able to assess the deep lobe and the involvement of the skull base or perineural spread, if there is any, as already mentioned. And of course, bone involvement cannot be assessed. And CCT could be, used to assess the involvement of the bone, like the structures in and around in the skull base or the mandible, if it is, it's an advanced tumor. As already mentioned, MRI is the preferred modality. We could, assess the involvement of, any of the facial nerve, the involvement of the skull base. The deep lobe can be assessed well, including the parapharyngeal space, and also if there's any, intracranial extension. So once we are done with the, with the imaging, so next. Imaging
Dr.
of
Shiv, can I
please
interrupt for a moment, please?
Yeah.
I'll like to ask the panel, if you permit me.
Yeah.
I'd like to ask the panel, particularly Dekru sir, about the diffusion weighted MRI. I have come across that in the literature, it says that it has got a superior diagnostic efficacy. So in Tata, are we doing it regularly, or we have some special indications for that? What is your take on that, sir?
Dekru sir, would you want to take that question?
So first you answer, yeah. I can take it, and then I'll tell them where to. Yeah, there is evolving data, but you go ahead, you answer, I'll add to it.
So actually, the diffusion weighted sequence is the preferred sequence for, when we do MRI to assess the salivary gland neoplasm, especially when you're suspecting malignancy. And also the ASCO recommendations, which I just put up, it also recommends the, going ahead with the diffusion weighted sequence, if, when we do the MRI. And in TMH, yes, we do those sequences as when we do MRI for parotid, to evaluate parotid tumors, especially. So would you add to that?
Yeah, so what I wanted to tell you that it is something that's evolving, but I don't want sometimes these kind of comments sound fancy and youngsters want the diffuse weighted. So if you read the ASCO recommendation, if my memory serves me right, it's recommendation 1.3. They say diffusion weighted is indicated primarily for perineural spread and or skull base involvement. And the recommendation.
I think, sirs.
My question is, do the regular MR, and if you want to look at that perineural invasion, do your diffuse weighted. Otherwise, the regular is fine.
Yeah, absolutely right. So that's why I initially didn't mention about the diffusion weighted, aspect of the MRI, because it's not routinely said. But then, yes, when you're suspecting malignancy, and especially perineal invasion, as you said, along with the infratemporal fossa involvement, the diffusion-weighted sequence of the MRI would be definitely useful. So we'll just move on to the next question, and that is, how do we, if we are suspecting a malignancy, do we do a PET scan, and or when do we do a PET scan? To the panelists, Dr. Gopal, would you want to take that question before I go to the other panelists?
Sure. So, I mean, usually the role of PET scan is in this situation is one of twofold, right? One is to determine whether there's you think this is a secondary tumor and there's a primary source to it. This is especially true when you're worried about skin malignancies, nasopharyngeal cancers, or other cancers where this is likely to be a secondary tumor. And the second situation is to look for distant metastasis or even nodal metastasis. So again, usually you do not do a PET scan up front. You have to have a histology. And histology has to be something concerning that makes you think it is one of the other, where you're looking for a primary site or you're worried about distant metastasis. So that's the usual situation we do it. For example, if I get a histology of squamous cell cancer, I'd be concerned that there might be a primary site somewhere. So therefore, I go ahead with the PET scan to look for a potential primary site. Or lymphoepithelial cancer is something that we see on and off in the parotid. And again, there's a need in lymphoepithelial carcinoma to exclude a primary site more commonly in the nasopharynx and much, much, much less commonly, say, in the lung. And that's when we do the PET scan. Or if you get a diagnosis of a large adenoid cystic cancer, again, you want to rule out distant metastasis. And again, that's where PET scans may be useful.
So for adenoid cystic, would you always do a PET scan, or would you just, stop short of doing a NCCT thorax? Because or when would you do a PET scan for adenoid cystic? Because most often you expect pulmonary mets, extra pulmonary mets is not often seen.
I think personally, if I get an adenoid cystic cancer, I just go ahead with a CT thorax. I don't really routinely do a PET scan. But now there's it's quite a bit of patient-driven push for PET scans. And so often the patient sometimes asks for it, and therefore we then accede to their request.
Right. So just to summarize, you could consider PET scan when you're dealing with high-grade malignancies like a salivary duct carcinoma or a high-grade mucoepidermoid carcinoma, advanced stage tumor, or a recurrent disease, as was being mentioned. And of course, there sometimes, I'll just come back to you, Dr. Manu, just a moment. So, of course, sometimes there are questions that come up whether you can do a PET scan to differentiate between benign and malignant lesions. Definitely a no, and you don't have evidence to support those kind of assessment of a salivary gland neoplasm. Definitely not to differentiate between benign and malignant. Dr. Manu, please go ahead, make your point.
No, not at all. I've actually asked that question. I'll lower my hand. And it was very nicely answered by yourself and De Cruz, sir. Thank you very much.
Right. Okay. So we'll just move on with this. So now that we have, the imaging, I think any points any of the panelists want to make as far as the imaging modalities are concerned while evaluating a salivary gland tumor before we move on to the tissue diagnosis? Anything anybody would want to?
I think there was just 2 points that I wanted to make that Dr. De Cruz brought up just now. One is the role of the ultrasound. We have the advantage of having a bedside ultrasound in our clinics, and therefore it is exactly for that reason that he described that it's extremely useful as an adjunct to physical examination, where sometimes we need to differentiate between what's intraparotid versus what's extraparotid. You can sometimes have very high level 2 nodes, which you think it's a parotid tumor, but it's actually a secondary metastasis in the lymph node. And having the ultrasound in the clinic really helps us just to apply that on the neck, and we can actually very quickly tell which is which. The second point is what you said about PET scan being differentiated between benign and malignant. It's important to remember that oncocytomas, which are usually benign, are one of the hottest nodules on PET scan in the salivary gland, even hotter than many malignancies. So that's why it is absolutely useless to distinguish between benign and malignant.
Absolutely. A point well made, Dr. Gopal. Going on to the tissue diagnosis, yes, there is always debate, not much of a debate, but still some people do believe that you don't need a tissue diagnosis. So let's elaborate on that. We definitely do need a tissue diagnosis to differentiate between largely infectious or inflammatory lesions, whether it's benign or a low-grade tumor and a high-grade primary, or is it a metastatic lesion? So definitely, whether it's infectious inflammatory versus a neoplasm, and in neoplasm, whether it's benign versus malignant, and in malignant, probably, if it could give us the grade of malignancy that we're dealing with. So, So, to the panelists, what would be the tissue diagnosis that you would go for? Would it be an FNAC or a core biopsy to begin with? So again, I'll go back to Dr. Manu. Dr. Manu, what is your investigation of choice for the tissue diagnosis, FNA or a
Yes, Dr. Shiv, I think that we as a protocol do go for an FNA. And if we have deeper swelling, it will always be better that we go for a guided FNA. And guided FNA always yields better results. Now, if we get inconclusive results for 2 or 3 times, then we can go for a guided core biopsy. So that's what we follow.
Right. So do all of the panel members agree that FNA would be the initial investigation of choice to get the tissue diagnosis? Yes, I can see that now. So FNAC, of course, definitely. Yeah.
One more thing that I want to add to this is actually when we think of core biopsy, there are some limitations associated with it. Now that if the skin is not involved, there are always chances of tumor seeding. And then at the same time, the 7th nerve or one of its branches can get damaged.
Yeah.
So it is actually better preferred when that skin is already involved, and if the FNAC has failed.
You mean the core biopsy? Right.
Yes.
So you want to say something?
Yeah, Shiva, 2 quick points I want to make. I've seen a lot of faculty saying that we don't need an FNAC. And I think you made this point, but you made it in passing. So I'm just going to reiterate it again. It's always safer to do an FNAC. Many people say we don't need it. Anyway, I'm doing a superficial parotidectomy. But an FNAC, doing it helps you in a lot of cases. You can avoid surgery. You can change your plan of surgery. And I'm not going to go into the various examples of when you do that. I'll just conclude by saying 4 needle in and you get history, it's much better. And please do it for all salivary. Core biopsy is only done when your pathologist is a little wishy-washy and wants more material, and you feel that diagnosis, if it changes, will change your treatment plan, or in sites where an FNAC is difficult to do, like an ectopic salivary gland tumor, then it's better to put in your needle under image guided and take out a core of tissue rather than just an FNAC. Yeah. So those would be the indications of.
Right. So just going further into the details of how an FNA would help us in our practice in the clinic, in your decision making or in the management. Dr. Sudhir, would you want to please elaborate on that? How would an FNA help you in the decision making process?
Yeah, doctor. I think I agree with Dr. DeCruz. And in fact, if you have a pre-operative diagnosis of the pathology you are dealing, it's always very useful for us to plan the surgery accordingly and counsel the patient accordingly. And especially, it can help us to avoid some intraoperative surprises. So if you have a benign, of course, in Tata Memorial Hospital, we see most of referred cases which are mostly malignant. Otherwise, in a routine practice, what we see is 80% of the parotid lesions are benign disease. So in that situation, still, sometimes patients like to plan the surgery accordingly, or they want more time to decision making, so we can advise the patient accordingly. In case of a malignant disease, again, the FNA, the only problem outside other than the FNAB is FNAB will be more specific, more sensitive in identifying the type of the disease and grading also. Whereas we may not be able to properly grade with an FNACs. I don't know, pathologists will be here, they can comment, but I feel that the grading may be changed even the while evaluating the full post-operative histopathology. So that probably if you feel we are dealing with a high-grade tumor intraoperatively, I will do a frozen section, which will give more better information.
Yeah, we'll come to that, sir, in a moment, about the frozen section. Thank you for those inputs. Before going to Dr. Neha, yeah, Dr. Neha, I'm just coming to you. So before I just come to you, I'll just make a point that the sensitivity and specificity as far as the FNA is concerned is pretty, dependable, and it definitely helps in the counseling and the surgical planning, of course, in the preoperative, in the clinics, for sure. And we have, various studies which have shown that the preoperative FNA, helps you decide as when a preoperative FNA diagnosis was available in terms of whether it was benign or malignant, the rate of upfront neck dissections were much more when compared to when you didn't have them, and also the margins were much better when you had an upfront diagnosis of having a diagnosis of malignancy. And also the surgical plan changed in about 19% of the patients. So definitely, yes, the FNA does help us in taking certain decisions preoperatively itself. Dr. Neha, please go ahead.
Yeah, thank you. Thank you, Dr. Shiva. So, FNA versus biopsy in a salivary gland lesion. I think clarity has come from ASCO guidelines, which has put an or between these. Traditionally, we have been preferring FNAs. We still prefer FNAs for salivary gland. This is one of the few sites in the body where we prefer FNA over a biopsy. But this time, ASCO guideline has put an or. You can either do an FNA or a core needle biopsy in salivary gland lesions. And in particular situations, core needle biopsies are better. What Dr. De Cruz very nicely highlighted, deeper lesions where repeated FNAs have not given adequate results. Now we have to understand that both of these have their own niche areas and own goals as far as reporting and as far as, when a common language between surgeons and pathologists is considered. So coming to FNA, the goal of the FNA in a salivary gland lesion is to identify neoplastic versus non-neoplastic, benign versus malignant, benign and low grade versus high grade malignant. And that is what is the should be the expectation from FNA of the salivary gland. And a high grade lesion is what is a surgeon looking for, the report of a high grade lesion on a salivary, which what you have said will help you in further planning your management, and where you will see the FNA of salivary gland will have the highest sensitivity as well as specificity. We have a Milan system of reporting of salivary gland tumors, which is similar to the Bethesda system. Milan is not yet very widely accepted, and there is a modified Milan which has come up from Dr. Ruta Gupta, the Australian group, and which is further stratifying these into multiple categories. But by and large, the goal of FNA in salivary gland is to distinguish non-neoplastic versus neoplastic, low-grade neoplastic versus benign, and high-grade. So those in a core biopsy, you have the advantage of tissue, you have the advantage of doing immunohistochemistry, and you have the advantage of doing molecular, considering that the salivary gland classification, the tumor histologies are becoming more and more molecular. And, the era where most of the salivary gland tumors will be diagnosed more based on molecular rather than, purely histology, because salivary gland tumors arise from common cells, and the presence of oncocytic change, presence of myoepithelial cells can be present in a wide variety of salivary gland lesions and do not essentially distinguish between one entity from the other, and the immunohistochemical markers are also overlapping.
Yeah. So before we'll just come back to you, Dr. Neha, once we go into the core biopsy, just in a bit. And how many among the surgeons would prefer the reporting done by the pathologist with the Milan? So is it being done already, or would you want it to be done, preferably? Dr. Sudhir, Dr. Gopal, your experience from Singapore, Dr. Manu, everybody can please chip in.
Dr. Shiva, I will start. I think in our institution, I feel that they have not started yet for the Milan system for reporting. But I think it will be useful to some extent. I think it's institute, like, Bethesda system, it should be standardized per institute. And one thing we have seen that even if it is non-neoplastic, there is a risk of, say, category 2, for example. In a category 2 Bethesda system, they say it is benign thyroid, whereas in category 2 Milan system, it is a non-neoplastic. Doesn't mean that it may be free of tumor, free of malignancy. But if the pathologist says a neoplastic with benign condition, then the chance of malignancy is much less. So in category 4, neoplasm benign, the chance of risk of malignancy is the lowest. So that's what I want to say. Probably a Milan system will be helpful for data analysis, reporting, as well as communication across various centers. I think I will like to listen to Dr. De Cruz and Dr. Gopal's opinion on this.
Gopal, do you want to go first, or should I make a comment?
No, I can make a comment. So we are not very much in favor of this system, and the reason being the range of different diagnoses that one can get in salivary gland neoplasms. I think in many sense of the word, we do get quite detailed diagnostics on FNACs for two reasons. One is that we always have a cytotechnician on site when we do these FNAs, whether us or ultrasound guided. Therefore, we always can confirm as much as possible adequacy of samples. And secondly, we always send a cell block with the FNACs. So we always have sufficient amount of tissue, even from an FNAC, to do further staining if particularly required. So because of that, I think getting a more detailed diagnosis is of greater value than a scoring system such as this. And I think a pathologist prefer doing that also because it guides treatment. So if you have a benign neoplasm, I want to know whether it's pleomorphic or it's Warthins. And the differentiation between the two matters on my management plan. One, I will consider surgery. The other one, I'll consider not treating. The second, and with malignancy, the same thing holds true. If I have a mucoepidermoid versus getting an adenoid cystic, my treatment is very different in how I manage the neck, for example. And so getting a detailed diagnosis as much as possible is more useful than a kind of a scoring system like this. The reason this works in thyroid is because in thyroid, you only have 1 or 2 diagnoses lumped as differentiated thyroid cancer. Whereas with the diversity in salivary gland, I'm not sure this is really going to take off.
Just to build on what Shiva and not Shiva, Sudhir and Gopal said, and to answer you very specifically, Shiva, you asked me whether I would like my pathologist to use this system.
Yes.
The system is important because we must understand that the complex thyroid nodules is different from salivary gland tumors. Thyroid nodules are seen in 8 to 10% of the population clinically, will be much higher if you do sono. If I go and operate 8 to 10% of the population, it's going to be a problem. So I need to fine-tune triage and operate certain nodules which are at the highest risk for malignancy. I definitely need a staging system in that case. In salivary gland, clinically, I would have made a diagnosis that this nodule needs to come out. And the majority of salivary that all of us attending on this conference today my pathologist information on whether I'm going to avoid surgery if they tell me it's non-neoplastic, whether I can alter or modify my approach, like for example, if it's a lymphoma, whether I can plan my surgery better if they tell me it is malignant disease, or if they tell me it's malignant and I have to search for a metastatic site elsewhere. I just need that information from them. The rest, my imaging will tell me, and I'll go in and operate and do exactly correct for my patient.
Right.
So right. I'm not fighting for this Milan system to, right. And you mark my words, 10 years from now, it won't be as popular as the Bethesda.
Yes, I totally agree. And I think for the same reasons that you and Dr. Gopal said, I mean, the variety of salivary gland neoplasms is huge. And as Dr. Neha already mentioned that the diagnosis of these salivary gland neoplasms is changing, and it's not just a morphological histomorphological diagnosis. You probably need in more tests, molecular testing and things like that. So yes, I do take your point on that. So let's just move on. And coming to core needle biopsy, we've already discussed it to a certain extent and considered when we can consider doing a core needle biopsy if the FNA is inadequate or if there are concerns for lymphoma. And if there are subsites wherein you're unable to do an FNA from, so that's when a core needle biopsy can be considered. And this is what the ASCO guidelines recommend as well.
Shiva,
Yeah.
also if it's very advanced and you're not doing surgery and you want to do molecular typing, look at various things, you can add that to the list of what you've put.
Absolutely, sir. Yeah. Definitely. Yes. So that will be the third reason why you would probably want to do a core, a biopsy there. And yes, again, previously Dr. Manu had raised concerns that, and of course, every time we discuss about core biopsy, there are concerns about facial nerve palsy, hematoma, and needle tract seeding. But this is one systematic review of 6 studies, which includes over close to 2,000 patients, wherein a core biopsy, the percentage of non-diagnostic core biopsies were very few compared to FNAs, which was statistically significant. It had a better sensitivity, specificity compared to the FNA, and fewer complications. Out of these close to 2,000 patients, only 3 patients, that is 0.3%, there was a documentation of hematoma, at least in the reported literature, and of which only 1 required some sort of a surgical intervention. And the risk of needle tract seeding is pretty minuscule, if I should say. So if required, if necessary, a core needle biopsy can be safely performed is what I would like to put across with this slide. Dr. Neha, would you want to add to that?
No, I just, yes, this paper kind of highlights that core needle biopsy is quite safe. The age-old, thinking that, the risk of needle tract seedling, which is the reason why many sites in the body previously, did not undergo core needle biopsy, high-grade malignancies where, you would not want high-grade needle tract seedling. This was, the salivary gland was considered one of those sites, and this paper kind of, mitigates that thought. So
Right.
core needle biopsy is quite safe.
Right. So now that we have investigated this patient, this was the FNA. The case 1 patient from our review suggested a low-grade salivary neoplasm Milan 4B, and the case 2 patient was a clear-cut, pleomorphic adenoma. So now again going back, this was the MRI of the first case, that is case 1, which shows a lesion involving the superficial lobe, just short of going into the deep lobe, and coming on to the extent of surgery for this, low-grade, salivary gland neoplasm or a pleomorphic adenoma. So these are the various options: enucleation, extracapsular dissection, adequate parotidectomy, and superficial parotidectomy. This is essentially for low-grade or a benign salivary gland lesion. So I personally have not seen or done an enucleation or an extracapsular dissection. But then there is a lot of literature that says that these are safe, prevents, recurrences, so on and so forth. So I'd like to know from the panelists as to when they would do what. Starting from Dr. Manu Malhotra, then we can go to all the surgeons one at a time. Dr. Manu, what surgery would you?
Shiv.
Yeah, would you prefer?
If it is a smaller lesion and scan, we have found it lateral to the 7th cranial nerve, we should go for a superficial parotidectomy. That's the protocol I follow. And if the tumor is less than 4 centimeters in deep lobe or in parapharyngeal space, we prefer total parotidectomy. And then for 7th nerve, we always try to dissect from the tumor as we subject the patient to post-operative radiotherapy to the primary site. And
Right.
then if there is a nerve encasement or invasion or the nerve is paralyzed, then we try to resect that portion. Afterwards, we try for a cable graft or using
We'll come to that, Dr. Manu.
yes.
We'll just stick to this case 1 and 2 for the moment, and we'll just come to a different, the need for doing more than a superficial parotidectomy. We'll just see in the next few cases.
That's
so,
right.
Dr. Gopal, what would you do for these, low-grade or benign lesions? When would you do enucleation or an extracapsular dissection, if at all?
I don't. I mean, for parotid neoplasms, almost always we do what I like to call an adequate parotidectomy, which can include a superficial parotidectomy, but can include more than a superficial parotidectomy. Like in the first case, you showed that with an extension to the deep lobe or potential extension to the deep lobe, to get an adequate rim of tissue, you probably need to clear a bit of that deep lobe adjacent to it to get a margin as well. So I think the term adequate parotidectomy is a broader sort of term to ensure that you actually are always aware of where the tumor is, and you get a good bit of margin around the tumor itself. To me, the only situation where I do an enucleation, there are only two situations where I do an enucleation. One is when there's definitely like a parotid lipoma, and even then I'm very certain that I'm far away from the nerve, or this is in a very superficial sort of space. The second situation where sometimes I consider an enucleation is when I do a sentinel node biopsy for a melanoma. In that situation, again, I have the comfort of having my nerve monitor. I do it under loops, and I also can identify and visualize the node quite easily, and potentially I can do an enucleation or a capsular dissection of the node itself. But even then, this is not something I tell my trainees, because this is not the exam standard answer. This is like what I do practice, because I don't want to subject the patient to a full-blown superficial parotidectomy for just a dissection of the node, for example, in a sentinel node situation.
Great points there, Dr. Gopal. Dr. Sudhir, any addition to what's been said?
I think I agree with Dr. Gopal, what he's saying. So when you have to define what is adequate parotidectomy. So if you see adequate parotidectomy, as you mentioned, with a rim of normal parotid tissue, it can be superficial parotidectomy, or it can be less than superficial, or it can be more than superficial. The traditional teaching for a pleomorphic adenoma presenting superficially to the facial nerve, the traditional teaching is to a superficial parotidectomy. And if a pleomorphic adenoma which is present in the deep lobe of the parotid, you have to do a total parotidectomy, because to reach the deep lobe, you need to remove the superficial lobe, identify, meticulously dissect the facial nerves, preserve it, and then go ahead and remove the deep lobe. So that's the traditional teaching. Adequate parotidectomy, we can add layer of complexity, and which is scientifically valid and correct.
Right. Great. D'Cruz, sir, your take on this.
Shiva, I'm going to make general comments. I again agree with all the learned panelists with me, but I want the youngsters to understand why these four terms came. Enucleation is a no-no. You're never going to enucleate a tumor without seeing a nerve. Fraught with high injury risk to the nerve, fraught with a high incidence of recurrence, particularly in the parotid, as you rightly said, 80% are pleomorphic. Extracapsular dissection came where you you put on your loops and magnifications and go just behind the capsule. Because when you do a superficial parotidectomy, you have a high incidence of a hollow on the face. You have a high incidence of transient facial nerve paralysis, and you have a high incidence of Frey syndrome. So people said that when 80% are benign, just go ahead of the capsule and avoid these. There is a meta-analysis about a decade old that did show the complications of transient facial nerve were less and Frey's was less. But this should be in very, very selected benign, very selected benign tumor cases. But by and large, all of us do what's known as an adequate parotidectomy. To me, superficial parotidectomy is also a terminology that's history. And the reason is, do a superficial parotid and look at the patient's face. You will have islands of salivary gland in the superficial lobe at a distance of what you've operated. So in all cases, we are going to do an adequate parotidectomy, take out the tumor with clear margins, and that's what we want to do. The debate comes whether you want to do a deep lobe, and that's a totally different debate at all. So in my book, all my patients are adequate stroke a near complete superficial parotidectomy.
Right. Great points, those. So this is one randomized trial that is often quoted. I mean, most of the literature that we have is, retrospective studies or prospective studies and systematic reviews of those. And this is the one randomized trial which is done for, partial versus superficial or a total parotidectomy in a, 101 benign salivary gland lesions with a mean tumor size of 2.7, and, most of the lesions restricted to the superficial lobe. And it showed significantly higher facial nerve palsy in a superficial or a total parotidectomy group, obviously because of the handling of the nerve. But otherwise, there were no recurrences in either of the groups if you did a partial parotidectomy or a superficial or total parotidectomy. Just for the sake of completion, I've just quoted this. And this is what, the systematic review and meta-analysis, which I think D'Cruza was, alluding to when he was saying that, 14 studies with 3,000 plus patients, which says that, no significant difference in tumor recurrences between the superficial parotidectomy with extracapsular dissection. But I personally have not done that. I don't, and I totally take the points that all the panelists made so far. It's not to be recommended. The minimum surgery that we would consider for any parotid neoplasm is an adequate parotidectomy, like what Sir said, or something more than that, depending on the case that we are dealing with. So, coming to case 3, this is one case that we had in some time back. It's a Warthin's tumor. As the description goes, this is one of the tumors which could present bilaterally, as this patient had. If you can just see in the clinical picture and as well as the MRI, the patient had Warthin's tumor bilaterally, left greater than, slightly bigger than the right, and no other symptoms other than that slight swelling that he saw on the left side. He's a smoker, of course. So the question to the panel is whether surgery versus observation first. Second is, if surgery, would we go ahead with one side and observe the other? Which side would we go ahead with the surgery? Just comments from the surgeons. Anybody can take that. Dr. Manu, would you want to go ahead with this?
Can you please repeat the question? I just missed it.
So this is a Warthin's tumor. He's a 57-year-old gentleman. He presented with a left-sided swelling. So on examination, there was a fullness on the right side, infraauricular area as well, as you can see. And the MRI suggests confirmed that there were bilateral, tumors, and FNAC, was Warthin's tumor bilaterally. So the patient didn't have any other symptoms other than the swelling on the, on the left side. So the question is whether to, what to offer to this patient. Should we just observe or operate? If we are going to plan surgery, which side are we going to operate first, or both sides? That's the question to the panel.
I think we'll go for the surgery on the left side first. I think the swelling is more apparent on the left side.
Left side. That's what brought him here to
like to have the views from Dr. Nair and Dr. D'Cruza as well.
Yeah. So,
so these type of, we need to frank discussion with the patient, and if patient is very apprehensive, and we have to be confirmed, we need to be sure that it is a Warthin's disease. And once it is confirmed, and I think if they have a discussion with the patient, and because traditionally they are benign disease, very rarely they have a chance of malignant transformation, but usually they are very benign disease. So we can suggest an adequate parotidectomy if patient is concerned about the swelling, because we can plan accordingly an adequate parotidectomy for this.
Yeah. D'Cruza, your take on this before we go to the next panel? Next case. Sorry.
Again, agreeing with what they have said, Sudhir, and all, the incidence of malignant is very, very low, less than 1%.
Yeah.
So I convinced my patient that surgery is not really indicated. But if you have a large cosmetically disfiguring tumor and the patient insists on surgery, I'll do it. And which side you do, I might do both at the same go, and it doesn't matter at all.
Right.
Because I don't see any advantage of there's no debate like that. Recurrent laryngeal nerve, if you fix one, you should do the other. If I've decided to operate both. If I've decided that one is small, one is disfiguring, I just operate the one that's big first. For your patient, I just tell him to put that beard a little more, and you won't see that Warthin's. And I would move to the next case on this.
Totally agree with that. Sir. Yeah. So we'll just move on with the cases. Sorry, just a minute. Yeah. So this is case number 4. This is 64-year-old lady she presented with a swelling of 1 month duration. She had some amount of weakness. That is, I would put it as lack of thalamus of the left eye, and FNA outside was suggestive of mucopurulent carcinoma, and at our institute, the review suggested a high-grade carcinoma. And this is the MRI, which shows the involvement of the superficial lobe and just close to the retromandibular vein. And the patient had this preoperative some lack of thalamus, suggesting that high-grade malignancy, the risk of the facial nerve being sacrificed or handled more. So the options for surgery in this case, to the panel, this is a high-grade carcinoma. Would we just restrict to a superficial parotidectomy, or would we go ahead with a total parotidectomy? In other words, how do we go about with this case for the extent of, how do we decide the extent of surgery in such a case? Dr. Gopal, would you want to start this?
Sure. So if you go back to the picture again, there are a couple of things here that concern. A couple of things that concern me. One is the fact that the skin appears to be a little bit potentially tethered or at least inflamed. So I'm concerned that whatever surgery I plan will have to include the skin as a margin. The second thing that I'm concerned about is the left eye closure weakness. So in my mind, I have to be mentally prepared to take the facial nerve. But as to whether I can restrict my dissection and resection to just the superior branch or superior division of the facial nerve will be based on what I see intraoperatively. So I'm sort of prepared to do a radical parotidectomy to clear this completely, as well as an appropriate neck dissection as well, together with the skin and the facial nerve if necessary. Right. If I can restrict that facial nerve excision to just the superior division, then all the better. If I can't, then I have to take the whole thing. And I'll also consider reconstructing or facial reanimation surgery at the first setting if I have access to that for this.
Yeah, thanks for that. So any additions to that for the extent of surgery, or should we just go ahead to the next slide for this patient, and then maybe we can take it from there, just in the interest of time that we are just having another next about 10 to 15 minutes.
I agree with what Dr. Gopal has planned. I think that should be it.
Yeah. So just the one question before we just move on to the what actually we did with this patient. Does the grade of the lesion decide the extent of parotidectomy? Of course, in this case, yes, but in general, or did go case by case?
Shiva, I'm going to again a general comment.
Yeah.
Don't bother about all these terms because youngsters are racking their brains before going into the operating room. Should I do a radical? Should I do a total? The premise in salivary gland tumors is to take out all the disease with clear margins. Give the name to the surgery after you finish the surgery. Don't give it before. When they're fighting coffee room that I wanted to do radical, you take out all the disease, you're good.
Yeah,
that's the important thing, both at the primary site and in the neck. That should be the case. Yes, grade is important because if grade is high, I'll always do the neck in those patients.
Yes. So actually, just sorry, go ahead, sir. Sorry, yeah.
I said I'd be more radical on my margins. That's it. I hand it to you.
Sure. So just to summarize what Sir said is that all these points probably, as Sir rightly put it, you can name the surgery after you have done that. But the point here is that you probably need to think over the entire surgery that you would do so that you could discuss that with the patient. Now, in this case, the patient has a lack of thalamus, but not a complete facial nerve palsy. So you need to discuss that with the patient. What could be the surgery, the need for facial nerve, sacrifice, the reconstruction. You would have to take a graft either from the leg or anywhere in the neck that is available, so on and so forth. So that way, this will just be important for the the surgeon who's seeing this patient to sort of counsel the patient right. And then, of course, yes, we can name the surgery that has been done subsequently.
Sorry to interrupt, sir.
Yeah.
Sir, we are late by half an hour, sir. So we need to wrap up in 5 minutes, sir.
If you could just give me 10 minutes, I would wrap up. So we started at 11:05. Just to complete this case, and then we could
okay, sir.
to the radiation oncologist, and then we wrap up.
Yes,
right?
sir, yes.
So the
Okay, sir.
question of margins for parotid tumor is always debatable, because there are no clear-cut trials which talks about these margins. The site, because there are multiple sites: the parotid, the submandibular, the sublingual glands. So there are multiple sites from which these tumors are involved. The diverse histology types. And of course, the most important one is the facial nerve. Now, you have to go many a times go through the tumor to save the facial nerve, or at least assess as to whether the nerve is involved or not. So all these things make the question of margins in parotid tumor a bit controversial, if I should say, put it that way. So, does the panel agree with me on this, or do we have a different opinion on this? If you can just make a short point on this, we can go ahead with the actual case. If there are none, okay, let's move on to this actually okay, they muted themselves. Thank you. So in this case, what actually happened was that this is the case here. We can see the main trunk here, and this is the lower branch, and the upper branch is being infiltrated by disease. So, so the panelist, what would you do in this situation? Would you still dissect the tumor further ahead and see if you could save it? Because the patient, we used the intraoperative nerve monitor, and there was some activity except for the zygomatic branch. The rest of the branches, there were activity. The upper trunk, that is the upper buccal and the frontal, but the zygomatic branch, the activity was minimal, suggesting that there is some amount of involvement of the nerve, and there was thickening of the nerve as well, as we can see here in the picture. Any comments on this as to how to go about it? Quick
Yes,
comments.
Shiva, I think
yeah,
what Dr. D'Cruz was suggesting, remove the entire disease, which I do agree in this particular situation, because you have already mentioned there is infiltration of the nerve. You don't have to completely worry about the nerve anymore, because you have to worry about the disease here. So you need to remove the disease completely, make sure that, and if you are retaining the branches, both the terminal portion as well as the stump, it is retained, we should consider immediate reconstruction, though the outcome may be poorer in case of already a palsied nerve. Okay.
Right.
So if there is no nerve palsy preoperatively and you are reconstructing, possibly the outcome will be better, but don't worry about the nerve, you worry about the disease, get for complete clearance as far as possible. This is my take.
Yeah, so that is exactly what we did. We sacrificed the nerve, and we did the reconstruction of the cut edges, the proximal and distal, with the sural nerve graft. And here I would just like to ask the question to the surgeons as well and the pathologist as to how they can help us with the intraoperative frozen section. So would you use the intraoperative frozen section at this point here once you've sacrificed the nerve? Yeah.
Shiva, I want to make two quick points on this. One, for the youngsters, please remember in parotid, you don't need margins as in squamous cell cancer where you need a 5 millimeter, 7 millimeter margin. You'll be hacking out everybody's facial nerve. So take out the tumor totally. You can leave back a beefy red nerve when you finish, but you don't leave crummy tissue on the nerve, whether it's benign or malignant. You have to take it out. If that amounts to sacrificing branches, sacrifice them. If you have expertise to reconstruct, do it. But precedence is disease control. You can put in those grafts and then radiate your patient. Outcomes are very, very poor. But you could do reconstructions if you have it. And the last point is, when you divide nerve, please send the cut ends for frozen section. Particularly if you're doing adenoid cystic, you'll be surprised something looks normal and your pathologist will tell you that there's disease at that cut end. So you sometimes even need to drill that facial into the mastoid to get a clean margin, because a recurrence there is awfully painful and no one can do anything.
Absolutely, sir.
That's it. Shiva, back.
Yeah, thank you, sir. Dr. Neha, would you want to add to this as to the intraoperative frozen? Just a quick word on.
So intraoperative frozen in this case, again, as Dr. D'Cruz has very nicely highlighted, will can tell you about if there is an ink margin or something which you want comment on that to decide the extent of surgery intraoperatively, whether that area is positive or not. And depending on the amount of tissue that has been given, there is a chance that, the histology can also be commented upon. But definitely the grade can be commented upon, that is high grade versus, high grade. And subtyping, there is a chance that the subtyping of the tumor can also be, identified in a frozen section.
Right. And here in this case, again, that the nerve cut end of the nerve sent frozen, it was positive, so we had to revise the cut end, and then once it was negative, then the nerve graft was put in. And of course, neck dissection, of course, we would consider in T3, T4 and high grade tumors, and of course in an N+ neck, and levels 2 to 4 could be sufficient in an N0 neck, and in an N+ neck 1 to 5. So I'll just run through this in the interest of time. Indication for adjuvant radiation. Shweta, please make a point on this about the indications for adjuvant radiotherapy.
Yeah, right. So, Dr. Shiva, I think, yes, we have got all the major indications for adjuvant radiation. Actually, there is no level 1 evidence or strong evidence for that, but in multiple series, RT has been shown to decrease at least the loco-regional recurrences, and all high-grade tumors, T3, T4 tumors, close margins, involvement of the facial nerve, lymph nodal metastasis, we do irradiate the primary, and in the high-grade as well as T3, T4 tumors, we actually irradiate electively the neck also, at least till the 1B and 2 levels. So yes, for this particular case, we will do RT.
Right. So this is one of the NCTB database wherein, which shows that adjuvant radiotherapy improves survival in both early and late stage in the presence of adverse features. That is, if it is adenoid cystic, intermediate, high grade, positive margin, and in an N+ neck. Of course, adding chemotherapy, that is adjuvant chemoradiotherapy, there's not enough evidence still. Evidence is, building on. There are at least two randomized trials and one non-randomized trial going on. One in the United States, one in France, and one in China, which is a non-randomized trial. Hopefully, by the turn of 2030, we should have some amount of evidence on these aspects for parotid malignancy that is concerned. So, Shweta, yes, sir.
I want to make a little contentious statement, and Sarmani knows this because we've discussed it on a telecon for a patient. The ASCO guidelines that you recommend post-operative radiotherapy for even the earliest adenoid cystic. So adenoid cystic, everybody gets radiotherapy. Show that Lee's meta-analysis. Views of you and any other radiation oncologist on the panel. Because I operated a very good-looking guy with a 1 centimeter adenoid cystic. I got it out well. And with these ASCO guidelines, I was a little scared whether I should give him RTS and to Sarbani. Both of us decided to observe. So comments from the radiation oncologist, you, Gopal, maybe this, and even if Sarbani is there, she can make the comment.
Shweta, do you want to just take that question?
Yes, sir, I absolutely agree. In fact, in our hospital also, we are not irradiating every resected adenoid cystic carcinoma. We tend to individualize our decision. Both the United Kingdom and ASCO guidelines say that RT for all resected adenoid cystic carcinomas, but for very low grade, less than 2 centimeter tumors, which can be observed very well and the patient is reliable for follow-up, we are actually not irradiating or giving them adjuvant RT.
Right.
Shiva, can I just make a quick comment here?
Yeah, man, please go ahead.
And maybe, sir, if you remember, the other thing that you taught me and is also, if you look at extra salivary sites, tumors, then we need to seriously then salivary in these.
Just moving on, just this one. You recurrent pleomorphic adenoma. When would you do that, Shweta?
Sir, so typically we are doing it, we consider it at least for only when there is a multiple recurrences or where there is a multifocal recurrence or the subsequent salvage surgeries can be very morbid. But usually even for one single recurrence in a pleomorphic adenoma, adjuvant radiotherapy and the typical salvage strategy remains surgery.
Yeah. Diku sir, when would you consider for adjuvant radiotherapy in a recurrent pleomorphic adenoma?
In my book, more, if nice to oncologists swear is the radiation They recommended some of the benign indications for radiotherapy, recurrent pleomorphism. But we moved those days. The reason is surgeries become much better. You can reanimate the face. So when you have a recurrent pleomorphic, you take out the whole block of tissue. Don't go in and fish out these small nodules. It's like you have rice grains that have spilt. You just clean the entire area. So I kind of take out the entire block with the masseter muscle and it comes out much easier. Reconstruct the nerve. It's kinder to the patient than giving pleomorphic adenoma. I mean, than giving
radiotherapy. Point taken. Yeah.
But I have seen people who have nodules at quite a distance away from adenoma. I'm observing you need the pathology to be well reviewed. Sometimes these are low-grade tumors that have been missed and have been labeled as pleomorphic.
Right. So great points. Those just skip that, and just the last case for the day: metastatic adenoid cystic carcinoma. This is from the parotid gland. The patient has only metastasis. So the question here: so would and then observe what would you do for the lung? And we end this panel. I think we'll start from the surgeons. Dr. Manu, would you want to just make your point? Metastatic involving the parotid lung, metastasis, nodules in the lung.
If it is not stage T4B, we rate the primary.
Right. And observe the lung. The patient is asymptomatic for the lung metastasis as of now. Yeah.
Shiva, I'm going to make 1-2 points just in the interest of time. I'm sorry to sound overbearing. It's always in cancer, you want loco-regional control. So you want to operate that local disease, provided it is not morbid, and you know that the lung lesions are not going to kill the patient. The longevity is more. But the entire temporal bone with metastasis in the lung, which doesn't really make sense at all. So if you've got isolated metastasis, the tumor's not very high grade in the lung, I might pardon you if you did that. So if the surgery is not morbid, go in and operate the primary. It's kinder on the patient. Lung metastasis can be indolent for years, and now as there is more and more progress on molecular precision medicine, various other drugs coming in, treatment of those metastases are evolving. And if it's an isolated metastasis, you can even go in with VATS and remove it. So the premise is operate if the surgery is not too morbid and the patient's going to live long.
Point well made. And due to the interest of time, I think I'll have to stop right here. It's been a great panel discussion. I would like to thank all the panelists for bringing in their points and discussing so actively. Thank you all. Thank you once again.
Thanks a lot.
Thank you.
Thank you.
Over to you. Yeah.
Thanks to all.
It was a wonderful moderation by Dr. Shiva Tyagarajan. I thank Dr. Shiva and I thank our expert, Dr. Anil K. D'Cruz sir, Dr. Sudhir Nair sir, Dr. Manu Malhotra, Dr. Neha Mittal, Dr. Shwetab Sinha, and Dr. Gopal Iyer sir for their remarkable discussion and highlighting the important points on parotid tumor. Moving ahead with the next case presentation and discussion on carcinoma larynx hypopharynx. The moderator for this session, the experts for this session are Dr. Alok Thakkar. He is professor and head otorhinolaryngology and head and neck surgeon, AIIMS, Delhi. Dr. Deepa Nair, she is professor, head and neck surgical oncology, Tata Memorial Hospital, Mumbai. Dr. Elizabeth Matthew Aipe, she is professor, head and neck surgical oncology, Regional Cancer Center, Thiruvananthapuram, Kerala. Dr. Devendra Gupta, his professor, otorhinolaryngology and head and neck surgery, Army Hospital, R&R, Delhi. This session is moderated by Dr. Shikhar Shawnee, his assistant professor, head and neck surgical oncology, Homi Baba Cancer Hospital and Research Center, Mullanpur, Punjab. I request Dr. Shikhar to please take over.
Thank you, Teertha. Good afternoon, everyone. So moving on from parotids, we'll now move on to probably one of the most contentious and controversial domain of head neck, that is the larynx and hypopharynx. We'll be starting with the case presentation. The case is presented by Dr. Vimni Gautam. She's pursuing her MCH from AIIMS Delhi and is currently in her second year. And do we have all the experts on board? Alok sir? Deepa ma'am?
Hi, good afternoon, Shikhar.
Good afternoon, ma'am. Alok sir, are you there? Dr. Elizabeth ma'am? Dr. Devendra sir?
Yes, hi.
I'm here.
Hello. Hello, ma'am. I think Alok sir is not yet online.
I can see him, but I think some problem with his mic.
Good afternoon, sir.
Good afternoon. Do you not hear me?
Yeah, we can hear you now, sir.
Right, okay.
Vimmi, can you start sharing your screen?
Yes, sir.
Yeah, go ahead and all the best.
Thank you, sir. Good morning, everyone. I hope my screen is visible and I'm audible.
Go ahead.
Yes, sir. So I'll be starting with my case presentation, which is a locally advanced hypopharyngeal malignancy. My patient is a 57-year-old gentleman who is a farmer by occupation and is a resident of Bagpat, Uttar Pradesh. He presented to us with the chief complaints of difficulty in swallowing solids more than liquids for the past 2 months, associated with change in voice for the past 20 days. So the history of presenting illness is that the patient was apparently asymptomatic 2 months back, following which he developed difficulty in swallowing solids, which was insidious in onset, started initially with a mild throat pain and foreign body sensation during swallowing, and it gradually progressed till the present state where the patient is able to take only semi-solids and liquids.
Vimmi, can I just stop you there for a moment? Can you move on your slides also? We can't see the slide of the history.
Yes, sir. Sir, can you see it now?
No, we can just see the introductory slide. Yeah, go ahead.
Sir, in the slideshow mode, I think my...
No, it's okay. Go ahead.
Okay. So, as I said, the patient was apparently asymptomatic 2 months back, then difficulty in swallowing for solids, which was insidious in onset, started with mild throat pain and foreign body sensation, and progressed till the present state where the patient is taking only semi-solids and liquids. This was also associated with pain, which was moderate in intensity, radiating to the right ear and relieved with analgesics. There is a history of change in voice for the past 1 month, which has gradually progressed to a state where the patient now has weak voice, more so during exertion. There is a history of right-sided neck swelling for the past 1 month, which is insidious in onset and gradually progressive. History of persistent coughing during swallowing liquids since the past 20 days. There is history of difficulty in breathing during exertion. However, no history of labored breathing at rest. No history of difficulty or pain during neck movements. No history of cough with hemopsis. And there is no history of significant loss of weight or appetite. Past history, and the patient has no known comorbidities like diabetes mellitus, hypertension, ischemic heart disease, tuberculosis, or any other depressive disorders, any previous malignancy. There is no history of radiation exposure in the past and no history of any previous surgery or significant trauma. Personal history: is a resident of Uttar Pradesh, educated till class 8th, farmer by occupation. He's married, has 2 children. He's on mixed diet with normal bowel and bladder habits and has a normal sleep pattern. He's a chronic bidi smoker, 25 pack years, and has a positive history of alcohol consumption of about 60 ml twice weekly for the past 16 years and has got no other addictions. And at present, he is abstinent since 3 months. There is no other similar history in any other family member. So my summary based on the history is a 57-year-old gentleman, farmer by occupation, no known comorbidities, history of chronic bidi smoking and alcohol abuse, presented to us with dysphagia for solid since 2 months and associated subsequently with change in voice, neck swelling, referred otalgia, and coughing during swallowing liquids. So this is my history part.
With me?
Yes, ma'am.
Deepa here.
Yes, ma'am.
With this history, what is the probable subsite which you think would be presenting, and what would be a provisional diagnosis?
Ma'am, based on the history of my patient, the probable I'm likely to be dealing with a pathology of the hypopharynx or supraglottis, or it could also be a cervical esophagus pathology. And my likely diagnosis is a malignant tumor in view of the short-term history and history of addictions and advanced age.
Why do you call this a supraglottic and a hypopharyngeal primary? Can you give some reasons for them?
Yes, ma'am. And so the first symptom that my patient presented, he initially had a foreign body sensation in the throat, associated with subsequently with difficulty in swallowing solids, which is more common with a hypopharyngeal malignancy, and can also be present in a supraglottic cancer, which and change in voice, dysphagia followed by change in voice supports that. And referred otalgia is also a symptom which is present in a number of cases in hypopharyngeal. About 75% of advanced hypopharyngeal malignancies can present with referred otalgia.
Can you tell me the pathway for the referred otalgia in this patient?
So, ma'am, in this patient, the referred otalgia is mainly because of this convergence projection theory, where several nerves share the same common neural pathway. So, in this, it is because of the internal laryngeal nerve, which pierces the thyrohyoid membrane, joins the vagus and in the superior vagal ganglion, along with the Arnold's nerve from the external auditory canal. The juxtaposition of these two neurons in the superior vagal ganglion is responsible for referred otalgia.
What about Jacobson's plexus? Where does Jacobson's plexus get involved?
Jacobson's plexus is actually supplies the middle ear, the medial part of the tympanic membrane and middle ear. And here, in cases of lesions extending into the oropharynx, that area, it is by the glossopharyngeal nerve. The nerve supply is by the glossopharyngeal nerve. So, and Jacobson's nerve branch of tympanic branch of the Jacobson's nerve from the middle ear, they synapse in the glossopharyngeal ganglion in the jugular foramen. So there.
So supraglottic, if the patient had a supraglottic tumor, the pain would be more deep-seated in the ear compared to a hypopharyngeal cancer. Yes. Good. Dr. Thakkar, Dr. Elizabeth?
No, I think that's been a comprehensive discussion.
So can I move on with my examination?
Yes, please.
So general examination, my patient is conscious, cooperative, moderately built and nourished. His vitals are stable. He's maintaining saturation at room air of around 98%. The body mass index of the patient is 21.4 kg per meter square. His ECOG performance status is 1. He has got no stridor and is comfortable at rest. There is no obvious pallor, icterus, cyanosis, clubbing or pedal edema. Systemic examination of the cardiovascular system, respiratory examination is normal. Examination, my patient with no oral submucous fibrosis, no loosening of tooth. Examination, the upper lip, lower lip, anterior 2/3 of the tongue, upper and lower gingivobuccal complex, floor of mouth, hard palate and RMT are within normal limit with no obvious nicotine staining in the oral cavity. Oropharynx, soft palate, tonsil and tonsillolingual sulcus is within normal limit. The base of tongue, tonsil and vallicula are soft on palpation. For the neck examination on inspection, there is an approximately 2.5 into 2 centimeter swelling at the level of the upper border of the thyroid cartilage, which seems to be approximately 1.5 centimeter away from midline. It moves with deglutition. However, there are no obvious scars, sinuses, or fistula present on the skin of neck. On palpation, first the findings of inspections were confirmed, and a swelling of size 2.5 into 2 centimeter, which is firm in consistency, tender on palpation, and swelling appears to cause widening of the laryngeal framework. Laryngeal crepitus is present, mobility is present. There is no obvious thyroid swelling palpable. There are no neck nodes palpable. The trachea is in the midline, and there is no obvious suprasternal fullness. We did a fiber optic laryngoscopy for this patient. So I'll be playing the video of the fiber optic laryngoscopy. Sorry. So the fiber optic laryngoscopy in this, here we can see the vallicula, which appears to be free, and the epiglottis.
So Vimi, we don't see your video.
Okay, sir. One second, sir. Sir, I'll play it separately. Sir, is it visible now? Is my screen?
Mm-hmm.
So this is the fiber optic examination, fiber optic laryngoscopy. Here we can see the vallicula, which appears to be free of disease. The appearance
We don't see it. We don't see it. Wow. So when you did shared screen and you said PowerPoint, sometimes it asks you a question. I think I'm not a great expert on Zoom, but it does ask you questions with regard to whether you want to enable videos and sound or something.
I just want to add one thing. When you're just doing a screen sharing, just click on the option on the screen, and you can just go in the presentation mode then.
Sorry, say it again so that she can understand.
Dr. Vimi, can we share the video from our side?
Yes, ma'am.
Okay, can you just unscan the share the screen?
Dr. Vimi, Devendra this side.
Yes, sir.
Till the time the video is being shared, can you elaborate on the swelling which you had described? So what type of swelling it is? Is it a lymph node or it is something else in the neck?
Sir, the swelling does not appear to be a lymph node. Frankly, it appears to be an extralaryngeal spread of the disease via the thyrohyoid membrane, causing expansion of the laryngeal framework. So, does not appear to be a lymph node, and it appears close, reaching the skin subcutaneous tissue.
Right. So, can you tell us the routes of spread of laryngeal and hypopharyngeal cancers?
Yes, sir. So, hypopharyngeal cancers from the PFS, so the laterally they can extend via the thyrohyoid membrane, and the they can extend via the thyrohyoid membrane, cause exolaryngeal spread into the neck as a neck mass. Also, they can cause erosion of the thyroid cartilage and cause extralaryngeal spread laterally, medially, and anteriorly. They can extend into the supraglottic part of the larynx and causing involvement of the paraglottic space there. And inferiorly, it can extend via the pyriform apex into the posteromedially and inferiorly postcricoid area and cricopharynx subsequently. And superiorly, the disease can extend into the oropharynx, vallicula, and base of tongue area.
Right. So, by your history, can you tell us which all areas it is involved? Suppose it is a hypopharyngeal cancer.
Yes, sir. So my patient has a history of dysphagia, which explains a probable location either in the post-cricoid area or piriform sinus. And referdotalgia supports the diagnosis of piriform sinus, along with the history of aspiration present, which implies the involvement of the paraglottic space causing vocal cord fixity, thereby resulting in aspiration. So supraglottis, it's extending onto the supraglottis and piriform sinus.
Right. I think we can move ahead.
I think in this conversation, Vimy, I think you also need to state that hypopharyngeal cancers are prone to spread submucosally, and the average spread is supposed to be 10 millimeters. Of course, it can be very variable, and also that you can have skip lesions.
Yes.
I mean, this is part of the description.
Yes, sir. That is in hypopharyngeal cancer, submucosal spread. So the fiber optic laryngoscopy, we saw the epiglottis. So now we can see a mucosa covered bulge present in the region of the right aryepiglottic fold. This is the arytenoid and the interarytenoid area. So we can see the left arytenoid seems to be mobile, whereas the right side of the mammillary seems to be fixed. We can now, moving below down, we can see pooling of secretions along. This is the interarytenoid area, which seems to be slightly edematous. This is the opposite side PFS that we are seeing, which seems to be free of disease. And now moving on to the piriform sinus of the right side, we can see an ulceroproliferative growth involving the medial wall, lateral wall. The inferior extent cannot be visualized here through the disease side. So the aryepiglottic fold is involved, both laryngeal and hypopharyngeal part. And the true vocal cords are seen now, and they appear to be free. Both bilateral true vocal cords appear to be free. So
Vimy, if you want to assess the inferior extent of the lesion, what additional evaluative procedure or investigation you want to do? What additional procedure you want to do to assess the inferior extent or the lower extent? You said it's not clearly visible by your nasopharyngeal laryngoscopy.
Yes, ma'am. Ma'am, actually, by inferior extent, I mean the piriform sinus apex and the post-cricoid area. They are best visualized by a direct laryngopharyngoscopy, rigid direct laryngopharyngoscopy. But the inferior extent, as in the cricopharynx and the lower down the esophagus, that we can have a better idea with a fiber optic laryngoscope also. So to see if the lesion is involving the piriform apex post-cricoid area, I would like to do a rigid direct laryngoscopy.
Yeah, one option is to go for a rigid scopy. The second option is you can put an esophagoscopy. Sometimes you will be able to negotiate if it's not really filling up the lumen. The esophagoscope can negotiate, and while withdrawing the scope, you can assess the inferior extent of the tumor. And the third option is your radiological evaluation of the inferior extent.
Yes, ma'am. Okay.
So with me, there's, as Dr. Elizabeth said, there's transnasal esophagoscopies are coming up much more, especially to assess these areas. And these are office-based procedures where you use a thinner pediatric esophagoscope. Our main problem is insufflation. We don't have insufflation with our routine fiber optic scopes. So by doing a transnasal esophagoscopy, you can insufflate and visualize a low extent of tumor. So you should know that this is an office-based procedure, which can be done even by head neck surgeons. And you don't need to necessarily refer it to a medical GI for the same.
Yes, ma'am.
But good so far. Go ahead.
Yeah, one more thing to add. Actually, we also do this esophagoscopy to assess the inferior extent. But as Dr. Deepa said, if you have only a laryngoscope and there is no option of an insufflation, actually what I do is I introduce even that laryngoscope down and ask my nurse to inflate through a 20 cc syringe. She can inflate air inside through our suction port. So in that way, you can do the insufflation, and maybe in selected cases, it will be useful, even at the office, even as an office procedure. So even with whatever limited facilities we have, even with the laryngoscope, that's what I am doing. If we don't have an esophagoscope, you can insufflate through a 26 syringe. Okay, go ahead.
So this is the same diagram presentation of the fiber optic laryngoscopy. So just that the medially, the retroarytenoid area seems also to be edematous in the disease. Rest, as we have seen in the fiber optic. We can change the slide. So based on my history and examination, the history of dysphagia towards solids, neck swelling, referdotalgia, hoarseness, and coughing during swallowing, associated with a growth that was epicentered in the right piriform sinus and extending anteromedially and superiorly to involve the ipsilateral supraglottic larynx, causing fixation of the right hemilarynx. This is my summary based on history and examination.
Dr. Vimi, staying on the same theme of improving inferior visualization. So, of course, you can do a transnasal esophagoscopy. You must have done one.
Yes, sir.
But what else can you do to improve visualization of the hypopharynx?
So we can ask the patient to puff his cheek, perform a Valsalva, so that the piriform sinus can be easily visualized. We can go down via the opposite side normal piriform sinus or through the post-cricoid area to see the lower extent of the disease.
So you can see a little bit more of the hypopharynx by doing the Valsalva or asking the patient to bend forward. But of course, that only gives you a little bit more, but you should do that.
Yes.
Yes. And in your summary, there is no mention of the neck swelling. You were describing the neck swelling.
Ma'am, I have mentioned it, dysphagia and associated with neck swelling, referdotalgia. Sorry.
Okay, there are no enlarged neck nodes?
No, ma'am, there are no enlarged neck nodes palpable.
And the crepitus is okay?
Yes, the laryngeal crepitus is present, yes.
So no can I ask one question? Can I ask one question?
Yes, sir.
I'm Yoshimoto from National Cancer Center for Tokyo, Japan. I'm a head and neck surgeon. In Japan, narrow band imaging is very popular in Japan. And we always check the superficial area of the hypopharyngeal and the cervical esophagus area by narrow band imaging.
Yes.
How about this case?
Yes, sir. We also routinely perform narrowband imaging with TNE in these cases, especially to see for the mucosal changes that occur in these cases lower down in the esophagus or the post-cricoid area. We also have a study from our institute that has studied TNE with NBI in all head and neck cancers. And there we found synchronous esophageal squamous cell neoplasias in 2.7% of the cases. So,
okay.
Narrowband imaging here.
So, Dr. Vimi, would you like to comment on something about neck movement, any restriction in the neck movement and its importance?
There is no restriction in this, yes. The importance, it signifies that if there is restriction of neck movements, the disease is likely spreading posteriorly to involve the prevertebral fascia. That causes restriction of neck movements.
Right, especially the extension.
Yes.
Would you like to give a diagnosis?
So, ma'am, based on the history and examination, my diagnosis is a malignant tumor of the hypopharynx right side piriform sinus. Clinical stage would be T4A in view of extralaryngeal spread and N0, clinical N0, M0.
How would you like to manage this patient?
We have through an FOL, we have taken an FOL guided biopsy. Now I'd like to proceed with the contrast enhanced computer tomography scan of the neck and chest. So I have a video, but I think I'll not.
Before the CT scan, clinically, you said it's a T4 disease, a cartilage.
Sorry, ma'am, your voice is.
So, is there any cartilage involvement? How will you assess? Yeah. Do you expect any cartilage invasion in this case?
Yes, ma'am, there can be a cartilage invasion. When we palpate along the length of the thyroid cartilage, there is tenderness. On clinical examination, if there is tenderness in the area of the thyroid cartilage, that can clinically point out towards invasion of the thyroid cartilage.
Yeah, the tenderness can point towards a perichondritis or a cartilage invasion, but you have an extralaryngeal spread which is coming out through the thyroid membrane. So anyway, it is deeper. Yes, you can proceed. So sorry for the, my internet connection is very unstable. Yes, proceed.
This is the contrast enhanced computer tomography scan. So these are the axial cuts, and this is the soft tissue window. Here in the first cut, we can see the mandible and the oropharyngeal lumen. This cut was put to show that the oropharynx part, the base of tongue, vallicula, those areas are free. In the second part, we can see the appearance of the epiglottis, and the vallicula appears to be free. And so far there are no significant. So far there appears to be no significant nodes. So now here we can see the appearance of the hyoid bone, just the appearance, along with the epiglottis. This is the median glossoepiglottic fold, vallicula. And here we can see the appearance of the soft tissue density on the right side. Probably the area of the thyroid. This is the area of the thyrohyoid membrane. So here we can see the appearance of a soft tissue density, and there is asymmetry as compared to the left side. So another cut, again the same thing. The disease is expanding to extend on either side of the hyoid bone. The appearance of the thyroid cartilage, just the appearance of the thyroid cartilage, and here we can see the disease to be present on either side of the thyroid cartilage. There is an extralaryngeal spread, and with slight narrowing of the lumen airway. And this is the external carotid artery. This is the common carotid artery, and this is the internal jugular vein. The disease in this cut, we can see that the disease is abutting the common carotid artery, but there appears to be preserved fat planes, but we cannot definitely comment upon that. But there appears, the fat appears to be preserved. The plane appears to be preserved, and its abutment is less than 180 degrees. So again, the thyroid cartilage and disease on either side, the abutment with the carotid, common carotid, and the medially and posteriorly here, the prevertebral fascia. The prevertebral fascia here we can see the fat planes here preserved, so that appears to be free. So this is the classical extralaryngeal spread when we can see the thyroid cartilage and disease present on either side of it. In the second cut here, this is the area of the false vocal cords, and here we can see sclerosis of the thyroid cartilage as well. Sclerosis is also seen, and the arytenoid cartilage, the sclerosis of the arytenoid cartilage is also seen. This is the area of the true vocal cords, where slightly the paraglottic space seems to be paraglottic space seems to be involved on the right side, and the further down as we go, the subglottis seems to be free. The subglottis does not seem to be involved. In these cuts are also just to show that the subglottis is free of disease.
What is the lower extent of disease in the hypopharynx? That is also a very important thing. Dr. Elizabeth mentioned you can use radiology to look at the lower extent of disease in the hypopharynx.
Yes, sir. So the disease.
Can you go back and show us the lower extent of disease in the hypopharynx?
Yes.
Though, of course, radiology is not very sensitive. It won't show you mucosal disease, but nevertheless, you should be looking for it.
Yes, sir.
But anyway, you did look. The cervical esophagus is perfectly okay, and the lower hypopharynx seems okay on the scans.
So only CT neck was done. Was CT chest done in this case?
Yes, ma'am. And the CT neck and chest both were done, and in the chest there were no evidence of any metastatic disease. Actually, I have the video, but I'm unable to play that, ma'am. So I just added the image cuts.
Yeah, so you did CT as the primary radiological evaluation modality. When will you do MRI? Or is there any role for MRI?
Ma'am, for larynx and hypopharynx, CT is generally the first investigation of choice, and MRI can be used as for troubleshooting in cases where we have doubtful involvement of the cartilage, especially in early cases, or even in advanced cases, if there is exolaryngeal spread, but we have doubt about the cartilage involvement. So the negative predictive value of MRI for cartilage involvement is close to 99 to 100%, and it's highly sensitive. So in those places we can use an MRI.
Yeah, there are specific indications, like as you said, in early cartilage involvement. That is the first indication, and the second is in advanced stages in the prevertebral space involvement. So these may be the two specific indications: early cartilage invasion and prevertebral space involvement in the advanced case larynx. Any role for PET-CT in this case? PET scan?
Yes, ma'am. Advanced hypopharyngeal cancer. This is a case of advanced hypopharyngeal malignancy, and it's known that they are known to present with distant metastasis. The incidence reported is around 17 to 24% at presentation. So yes, if I have the facility in this, I would like to go for a PET-CT in a case of advanced hypopharyngeal malignancy to rule out any obvious distant mets.
Yeah, T4 or advanced hypopharyngeal cancers or extensive nodal disease or a lower level nodal disease, actually PET scan is indicated to rule out other mets and second primaries.
Yes.
So, Dr. Vemi, did you assess patients following, although you have given a very distinct history of aspiration,
yes, sir.
But still would you like to assess the patient's swallowing function?
Yes, so we performed a functional endoscopic evaluation of swallowing in this case. And there we found out that the patient was frankly aspirating, but he was able to cough it out of this thing. And his the pass score was around 6.
Right. So, will it change your management?
Yes, sir. If the patient has a dysfunctional larynx, this indicates that the patient has got a dysfunctional larynx, and a dysfunctional larynx warrants a non-organ preservation modality of treatment because there is no function to preserve.
Let me staying on the topic of evaluation of swallowing. Do you know of any office-based procedures other than fees for evaluating the swallow, which you as a clinician can do?
Ma'am, bedside we can do an evaluation of swallowing, like water swallow test. We can ask the patient for 100 ml to swallow 100 ml water, and if he coughs out upon swallowing, that can give us an idea that the patient is aspirating.
So a 100 ml water swallow test will be an initial screening tool for you. And since on history itself, the patient was aspirating, doing a fees would really be only of academic purposes in this patient. Suppose this patient did not have cartilage erosion, but had exolaryngeal spread. Would your management plan for this patient change?
Ma'am, exolaryngeal spread, but with a dysfunctional larynx, I would still go on with the same management plan. Because
suppose if this patient is, as you said, T4 hypopharynx with extralaryngeal spread, but no dysfunction, then what is the option? Or will you think about any other option other than surgery?
Yes, ma'am. So if there is a T4A disease, which is an exolaryngeal spread, that is through the membranes rather than eroding the cartilage, then I would, and the larynx is functional, then I would go for an organ preservation protocol. This would be the ideal case for a neoadjuvant chemotherapy, induction chemotherapy, and followed by response assessment, and then further treatment depending upon the response, appropriate local therapy depending upon response. So if the patient responds very well to induction chemotherapy, if there is either a complete or a partial response, I would like to give another cycle. After 2 cycles, I'd like to check for a response. If there is a good response, I would give another cycle and go on for a definitive radiation. And if the patient has progressive disease or less than a partial response, I would like to proceed again with a total laryngectomy.
Which evidence are you basing this on?
Ma'am, for hypopharyngeal cancer, the first randomized control trial was by EORTC 24891 by Lefebvre and colleagues, where they used induction chemotherapy in cases, though they did not specify the cartilage erosion in that study, but only 37% was stage 4 and most of the T3 carcinomas. So the main purpose of them there was that they tried to show non-inferiority of induction chemotherapy in their study by comparing the hazard ratio. Hazard ratio should have been less than 1.43 as compared to surgery. So they found out that the induction chemotherapy had a role in laryngeal preservation without compromising the overall survival and disease-free survival.
Do you know the updated results of the study?
Yes, ma'am. The 10-year results have been come, and the 10-year results show that in general, hypopharynx is a bad subsite with a very poor survival. The 10-year survival rates in both the arms are around 13.8 and 13.1%, 13.8 being in the surgical arm, and survival with functional larynx is around 8.7%. That is, there were 8 patients were alive in the chemotherapy arm, and 5 out of 8 were able to retain their larynx.
Good.
So can we have the perspective of Dr. Yashimoto? Sir, how do you treat these patients with hypopharyngeal cancers? Because you obviously have a significant experience with these in Japan. That's a T4A case, and I strongly recommend operation first as a surgical oncologist, because also this patient has already the swelling problem, and so I think in the concurrent chemotherapy is a very, very difficult job, and then so I think I always explain the patient about the treatment for such a case. For example, the concurrent chemotherapy is the very, very longest and longer and the narrow way to finish the treatment, but operation is the shortest and the widest way to finish the treatment. So that's why we strongly recommend the operation. So, but I think that finally I have to follow the patient request. If the patient like to preparation treatment, treatment. So we just we like to follow the patient request. But if you like to do the induction chemotherapy, so it takes more time to finish the treatment. So I have to talk with the patient about this thing. So that's fine. Basically, I recommend the operation. And when, if ever, do you recommend chemoradiation? So this case is the patient like to undergo the concurrent chemotherapy. We use the standard therapy using the CDDP, and this patient is a very young patient and no problem of the renal function. So we can do the concurrent chemotherapy, but generally, so salvage surgery is not so difficult for the larynx cancer than the hypopharyngeal cancer. Hypopharyngeal cancer, the salvage surgery is sometimes very difficult. So we have to talk with salvage surgery problem for the hypopharyngeal cancer patient. Yeah. I have very similar thoughts. Salvage surgery is very difficult for hypopharyngeal cancers. So generally have extrapharyngeal extension and infiltration into surrounding tissues. And if they fail radiation, it's a very difficult operation. If the patient has a recurrence, at the time maybe this tumor embedded into the carotid artery, because this tumor is very, very near the carotid artery. So that's why if the patient has a recurrence after the concurrent chemotherapy, maybe it's not curable. So that's why so we have to talk to the patient before the starting treatment. So Vimit is another randomized trial by Bovillian, which came out around the same time as EORTC, and that's quite instructive, because what the EORTC did was to give everybody chemotherapy and treat the responders with surgery. and the non-responders, treat the responders with chemoradiation and the non-responders with surgery. But if you look at the Bovilian trial, they gave everybody chemotherapy and then stayed with their initial decision. So their initial decision did not matter. And so they did give chemotherapy followed by surgery or chemotherapy followed by chemoradiation. What is instructive is that the EORTC did surgery only for the non-responders, while Bovilian did surgery for the responders and non-responders. And basically, if you look at that data, what it tells you is that the
overall survival
responders do very well with surgery. So the EORTC is actually choosing the poor prognostic patient and pushing them towards the surgery side. That is basically what the EORTC trial is doing. The poor prognostic group is being pushed to the surgery side, while the good prognostic patients are being pushed to the chemoradiation side. Evidence with hypopharynx remains difficult to get. There are always small series. But yes, the final trial, the final result of the ORTC or the long-term results with only a 10, 15, 13% 10-year survival could be partly ascertained because could be partly due to the fact that the good prognostic group, which is the responder group, didn't quite have the surgical treatment but had non-surgical treatment.
Yes, so in Bovilian et al., the randomization was done prior to the start of chemotherapy. And so there was a significant difference between the surgical arm and a non-surgical arm in terms of overall survival and loco-regional control, 63% versus 39%.
Vimi, how will you assess the response after NACT? After the neoadjuvant chemotherapy,
yes,
you are the treating physician. How will you assess the response?
So, ma'am, different trials have used, like generally, what is done most commonly is after 2 cycles of chemotherapy, the patients are evaluated with an endoscopic examination to see the endoscopic tumor surface shrinkage, and also as radiology is done to see the reduction in the disease volume. And and if depending upon that, the response is classified as complete response, partial response, progressive disease, or a stable disease. So complete response is the disappearance of all the macroscopic disease.
Sorry to interject. Unfortunately, this is all the time we have for this session. So maybe if you could get some closing comments from the examiners, and if I may request the examiners to rate Vimi's performance. Or maybe one last question from the examiners.
How would you follow up a patient post-CRT?
So, sir, post-CRT is the only, I would like to follow. First of all, I'd like to follow up the patient. I'd like to get a PET CT done for the patient at around 12 weeks post-completion of treatment to see for the disease status. And if there is no residual or recurrent disease, then I would like to keep the patient under follow-up bi-monthly, usually bi-monthly for the first year, then quarterly in the third year, and 6 monthly thereafter. And also I would like to do strict speech and swallowing rehabilitation for the patient post-chemo radiation therapy. And a TSA, I would like to do a thyroid function test when either first if the symptom onset or at 6 months, whichever.
So would that have any implication in your surgery, or would that would you take certain precautions to approach that area while operating, while taking the mucosal cuts?
Yes, sir. So usually while performing a total laryngectomy, when we do laryngeal entry, we do it usually from the vallicula, and we usually do it in that area. And after that, we depend on under direct view, we take the mucosal margins. Usually we give the entry from the opposite side. So we'd like to do the same manner, like I would like to enter the larynx from the left side in this case, and keeping the tumor under direct vision, I would like to take adequate margins.
Any other area where you can enter the larynx?
We can also enter laterally from the PFS.
The opposite PFS. Yeah. Great.
So my last question will be, how will you reconstruct this case if you are opting for a laryngopharyngectomy in this case?
So, ma'am, the main principle of reconstruction, the reconstruction modality would depend upon the size of the defect post excision of the primary. So, depending, I'd like to first of all evaluate the remnant pharyngeal mucosa for mucosal adequacy, its vitality and texture. And if the mucosa, I'll measure the mucosa, breadth of the mucosa at the level of oropharynx, midpharynx, and cricopharynx. So, if at the level of cricopharynx there is an adequate mucosa of around 2.5 to 3 centimeter unstretched, I would like to go for a primary closure of the neopharynx. And however, if there is less mucosa than that, then I'd like to do a patch pharyngoplasty. In cases, we can do patch pharyngoplasty either with PMMC or a free radial artery forearm flap. And sometimes the mucosa is very inadequate that it is just stripped off its prevertebral blood supply. So I'd like to take that mucosa off and do a circumferential pharyngeal reconstruction. That for best would be a free jejunal flap for a because mucosa to mucosal anastomosis is the most physiological. But although there are certain morbidities associated with that, I can also do a tubed radial artery forearm flap, a tubed ALT flap.
In Japan, also the jejunal flap is very, very popular for such a case.
Okay.
Okay, good. Okay, good presentation.
Thank you, ma'am.
Any closing comments from Alok sir, Deepa ma'am, Devendra sir? Then we can
talk.
Good presentation, short on time, but I think very well covered. So I hope it was a learning experience for all.
I echo Dr. Thapkar's comments. I think she's done very well. She's presented it very concisely, very clearly, and all the answers were to the point. So well done, Vimi.
Same here, Vimi. You did well.
Great, Vimi. Congratulations. Time to celebrate then.
It was smooth and crisp presentation by Dr. Vimi Gautam and very well moderated by Dr. Shikhar Shaune. I thank our expert, Dr. Alok Thakkar, Dr. Deepa Nair, Dr. Elizabeth Aipe, Dr. Devendra Gupta for their valuable discussion. Moving ahead to the last session, operative technique discussion, total laryngectomy. The experts for this session are Dr. Prathamesh Pai, his professor, head and neck surgical oncology, Tata Memorial Hospital, Mumbai. Dr. Purushottam Chavan, he is associate professor, head and neck surgical oncology, Kidwai Memorial Institute of Oncology, Bangalore. Dr. Richa Vesh, she is associate professor, head and neck surgical oncology, Tata Memorial Hospital, Mumbai. Dr. Saichi Yashimoto, Department of Head and Neck Oncology, National Cancer Center, Japan. The talk is by Dr. Mitali Dandekar. She is consultant, head and neck surgical oncology, Paras Hospital, Patna. I request Mitali ma'am to please share her screen.
So very good afternoon, everyone. So Poonam has asked me to be a presenter as well as a moderator for this session. So the module we'll be following is we'll present a particular step of total laryngectomy and we'll take comments from the expert panelists. We have a wonderful panel here and I'm hoping it turns out to be a very enriching experience and worth the wait before the lunch begins. So to begin, the larynx is a unique organ. I've used this diagrammatic representation and I shall be using it to explain a few steps in the course of my presentation. It is unique. It is unique because it forms a link between the pharynx and the airway and thus is instrumental in preventing aspiration. Also, it helps in phonation. So based on that, the indication for total laryngectomy by and large, general indications would be when this link becomes non-functional, when there is infiltration of the tumor in this laryngeal framework, or when treatment related to laryngeal conservation fails. Similarly, because phonation is a very important function of the larynx, it is incumbent upon the surgeon to rehabilitate every patient for voice. So keeping this in mind, we discussed the goals of surgery. It would entail extirpation of the entire laryngeal architecture,
along with exteriorization of the remnant airway. This unwieldy line actually represents the suture line, which would be performed after the exteriorization to form a robust neopharynx, either with a primary closure, augmentation, or buttressing. We would discuss each one of them as we go ahead in the presentation. And third, but not the least important, is voice rehabilitation. Principle similarly for oncological safety would be to assess the extent of the disease and subside and dictate skeletonization based on the extent and the subside. In unilateral disease, as is seen in this diagram, the thyroid lobe of the contralateral side can be preserved. Also, the inferior constrictors of the contralateral side can be preserved and can be used to buttress the suture line. I would like to get some comments from the panelists on the presentation thus far. Any tips or any other additions to the principles of surgery? Professor Pai?
Mithali, I think you have been very clear, and I feel the criteria for total laryngectomy have been streamlined till now, and now we will be looking at operating the patients who will not go in for either organ preservation or for an open partial laryngectomy. So it's very clear from your talk so far that the ones that we will be doing either total laryngectomy or a total laryngectomy with partial pharyngectomy or a total laryngectomy with complete pharyngeal resection would be the ones which have a cartilage destruction, function loss, as well as the ones that will not be suitable for organ preservation.
Dr. Yashimoto, I'm so sorry. Yashimoto?
No, I don't have any additional comment.
Okay. Dr. Chauhan? I think you'll have to unmute yourself. In the meantime, Richa, any comments on this?
Yeah, Dr. Mithali, I think very comprehensively you have presented, but I just wanted to elaborate on one point. Of course, in today's era, we have 3 indications for laryngectomy, very rightly put. So if it is locally advanced, it's a salvage setting, or it is a dysfunctional larynx. So I would like to, your opinion on when you talk about the dysfunctional larynx, would you be sending all the patients for the evaluation? And what extent or what criteria would you consider, the dysfunctionality to be the indication for laryngectomy?
I would like the comment from your side, Richa. Please elaborate.
So in TMH, what we are routinely doing now, previously the functional evaluation was not a part of the routine follow-up. Now all our patients, they go for the functional evaluation, and if there are clinical signs that are suggestive of aspiration, or if on performing the endoscopy, we can see that it is at least grade 7 or 8 on passport. So definitely a dysfunctional larynx, probably then we think of knocking out the larynx. There may be slight dysfunctionality associated with even, restricted cord and all. So when we say dysfunctional larynx, it should grossly be dysfunctional and not, minor dysfunction of the larynx. That's all I wanted to elaborate on.
Perfect.
The only thing, Vitali, I think the point should go across that the cartilage framework is paramount. So if your laryngeal framework is damaged, there is no point in doing a functional evaluation, because that larynx will not be worth preserving. So only the ones that have an intact laryngeal framework would you then consider doing functional evaluation. As on today, we will not use a functional evaluation alone to opt for a laryngectomy or organ preservation.
Perfect. So once the goals and principles and indications are clear, let's move on. Planning of incision. The factors which by and large dictate planning of incision would be adequate exposure, whether there was any airway intervention due to prior tracheostomy, and there are certain modifications we would discuss on this incision. The classic incision that is described as the apron or the glux or incense incision, which extends from the mastoid to the mastoid, designed ideally to maximize exposure. However, very obviously, the vertical limb or the extension of the vertical line of this incision is against the Langer's lines and may result into some kind of unsightly scar or fibrosis. It has then been modified that the vertical limb is negated and a transverse skin crease incision has taken over, by and large extrapolated from a thyroid incision where we managed to reach the level 2 or the hyoid in spite of taking a transverse incision. When there is a prior tracheostomy, the tracheostomy site is circumscribed. A separate stoma now is the most feasible design that is performed for a total laryngectomy, where the stoma is separated from the surgical site. Should there be a leak, the stomal site or the airway would be isolated from the rest of the surgical site, and that is the main indication for it. However, one needs to maintain caution to maintain an adequate skin island between the incision and the stoma, particularly in patients who are previously radiated. In fact, one would go further to avoid such incisions or such stomal designs for patients who have undergone radiation in the past. Also, there are certain modifications one needs to make on case-by-case basis, like skin infiltration. Any other tips anybody would want to add, Professor Pai?
No, I think you're very clear.
Dr. Richa?
None from my side, Dr. Mitali.
Dr. Savant, I'm sorry, I didn't in the last
Now, can you hear now?
Yes.
Yeah. Any laryngectomy which is not tracheostomy, I will try to see whether less than total laryngectomy can be done. And I'm always looking for a possibility for near total laryngectomy. So except that, rest of the discussion will remain same. And somehow I have found Glock-Sorensen incision I am comfortable with it. So very long neck only, I try to go for a horizontal incision. Otherwise, same incision gives you more clearance.
Okay, thank you. We'll restrict our discussion today for total laryngectomy only, and we'll gather tips and pearls of wisdom from the panelists based on only on total laryngectomy, if it's possible. Dr. Yashimoto, any comments?
I prefer the big U-shaped incision, right?
In all cases. Okay. So then moving on, after the incision is made, exposure superiorly would be above the hyoid bone to expose the suprahyoid musculature. Typically, when the submandibular glands are well exposed, it is considered to be adequate. Inferiorly, the suprasternal notch, and laterally, the sternocleidomastoid muscles must be clearly visible. We then move on to skeletonization of the larynx, also called as creating a paralaryngeal gutter, by release of the strap muscles, clear the central compartment in all cases, management of the thyroid gland, which may differ from patient to patient, and finally, devascularization of the larynx. One must complete the lateral neck dissection when indicated, so as the vessels are under vision before proceeding with the skeletonization of the larynx. Any comments on this by any of the panelists? Does anybody have any difference of opinion on the kind of steps that are followed for skeletonization of the larynx?
No, please go ahead.
Okay, so moving on, for first would be the release of the strap muscles. The sternal attachment of the straps, typically the sternohyoid and the sternothyroid, are released close to the origin, that is as low as possible to encompass the entire laryngeal unit. The omohyoid muscle also is released at the intermediate tendon. The central compartment now becomes very visible once the strap muscles are released, and the central compartment is cleared thus to expose the carotid artery. The sacrifice of the recurrent laryngeal nerve is essential such that the clearance is complete. Also, needless to say, the inferior parathyroid glands must be looked for and must be preserved the way one would preserve it in all cases of thyroidectomy. Coming to the management of the thyroid gland, typically it is advised.
Can I make a comment?
Yes, please. Yes, please.
I think it's very critical that your central compartment clearance is vital, especially in lesions which are involving the pyriform sinus coming onto the apex, when there is a cricothyroid escape of disease, and when there is a subglottic extension for glottic cancers. So it is very important to do the central compartment clearance. In a routine laryngectomy, a lot of focus is not on this, and ideally we need to do it, especially on the side of the disease. Your concept of only inferior parathyroid may be taken, wrongly here. The ipsilateral central compartment clearance is vital, but on the contralateral side, needless to say, along with your half the gland of thyroid, you should preserve the superior and the inferior parathyroids, because then you can have maximum preservation of parathyroid in the patient.
Perfect. We then move on to management of the thyroid gland. Preserve the thyroid lobe on the contralateral side. One must include the thyroid lobe in the specimen on the ipsilateral side. While in cases where there is midline disease, the isthmus is considered in the specimen and bilateral thyroid lobes can be preserved. Devascularization of the larynx. Now, this laryngeal pedicle is a branch of the superior thyroid artery. It traverses along with the internal laryngeal nerve and pierces the thyrohyoid membrane. On the contralateral side of the disease, as we discussed in the previous slide, the thyroid lobe is preserved and the laryngeal neurovasculature is sacrificed, as is shown in the encircled area. While on the ipsilateral side of the disease, because the thyroid lobe is sacrificed and the superior thyroid artery and the vein is ligated. Any comments from the panelists with respect to any difference of opinion with management of the thyroid gland in a laryngectomy? Dr. Yashimoto?
I think preserving the venous return from the thyroid is more difficult than the preserving the artery. So we have to take care of the venous return, for example, in the interthyroid vein or the middle thyroid vein. So we have to take care of the preserve the vein much more than yeah.
Okay. Richa, any comments?
Nothing. I just wanted to get everyone's opinion on like if you are doing a thyroidectomy for a locally advanced laryngo or hypopharynx cancer, and if the gland is frankly involved by the disease and not involved by the disease, would the extent of thyroid gland that we'll be taking out would vary, or we would still go by the concept of a hemithyroidectomy on the disease side?
Yeah, please go ahead with your opinion, Richa.
Okay. So I feel if there is a gross invasion to the contiguous spread and we see that the lobe is involved, probably we may go ahead with a little more extensive resection of the thyroid gland. Then we are doing it for the prophylactic and assuming that it is a lymphatic spread. But I would like to have opinion of other panelists as well.
Absolutely. So just the way we follow safe principles of oncological resection, we would go wide on the margins of the thyroid if it is involved. Any comments on that, Professor Pai?
I think from literature and from our own experience at Tata Hospital, we have realized that the involvement of the gland occurs in about 15% of patients. So it is very clear that this involvement is seen in the patients that have exolaryngeal spread beyond the cricothyroid membrane or erosion of the subglottic disease at the trachea. And in those patients, you may not need to actually preserve the thyroid gland. The whole focus of preservation of thyroid is primarily to preserve the parathyroids. And as the residents should be aware that almost 80% of our patients will turn hypothyroid in 6 months' time because all of these will require post-operative radiation. So I would not worry if I have to do a thyroidectomy, a total thyroidectomy in a patient, because you would need to clear the disease adequately. Like Richa said, if you have involvement of thyroid, you should not worry, but focus on the parathyroids then and try and preserve them.
Dr. Sawan, any additional point you would want to make?
Yeah, we should not take thyroid too seriously. It's a small price to pay. But needless to say, any extralaryngeal spread, you have to remove the thyroid. If it is less than T4A,
and you are ending up doing a laryngectomy, which usually you don't do nowadays, in those cases, you can preserve the thyroid.
So let's move on then. The next step in skeletonization of the larynx is the management of the inferior constrictor. Now, the inferior constrictor muscles are typically the thyropharynges and the cricopharynges, which are attached to their respective cartilages. Muscle is separated and preserved from the cartilage on the contralateral side of the disease. And on the ipsilateral side, the step is performed after confirming the disease extent from the mucosal end, that is after the laryngeal entry. We then move on to suprahyoid release. Once here, the body of the lesser and the greater cornu of the hyoid gland are bared by going as close in close proximity to the gland to release the suprahyoid musculature, because the lingual artery stays very precariously close to the hyoid greater cornu, and all attempts must be made to identify and preserve the lingual artery there. Once the hyoid bone is released, the pre-epiglottic space, the fat pad, is exposed. And as we move on into the presentation, we would delve more into management of the pre-epiglottic space. Any comments in the meantime about suprahyoid release? Any points to be made? If no, then let's move ahead. Tracheal cut and the airway transfer. The trachea is incised in the intercartilaginous membrane close to the lower border of the upper cartilage to preserve the membrane over the preserved cartilage. Typically beveling of the cartilage is avoided because it would expose the cartilage, and perichondritis predisposes to stomal stenosis. The posterior wall, that is the membranous trachea, is incised after removing the endotracheal tube, and the airway is transferred. So this step is the first step for laryngeal entry when the airway is not secure with a prior tracheostomy. Any tips from the panelists about management of the tracheal ring while performing, to ensure that there is no stenosis or to ensure a good stomal size? Professor Pai, sir?
The stoma is very important, and we need to look at the adult male and adult female trachea. The adult male trachea is quite large in bore, yet when we actually when we do maturation of the stoma, we find that you might not get an adequate diameter. In most of our patients today, we will consider putting a tracheoesophageal prosthesis. And it is very vital that you have an adequate size stoma for maintenance of this prosthesis. So please understand that the tracheal rings are not separate rings. You might have conjoint rings. And when you go along incising the trachea, try and preserve as much membrane on the trachea as possible. And as you go towards the membranous part of the trachea, at that point, you can bevel at 1 or 2 rings distance above. So you might end up with a more oblique, wider stome than just the horizontal cut. So the trick I find useful is to go towards the end at the junction of the membranous and cartilaginous part, and then bevel for a ring or 2 distance above on the membranous part. So I get some more trachea for the maturation. Of course, if you have a subglottic disease, that is a concern. And if you have already a pre-operative tracheostomy, then you'll be concerned with the amount of trachea that you have.
Dr. Yashimoto, anything differently that you do?
Always we like to check the blood supply of the end of the trachea. So we always check the vascularization, good vascularization of the trachea end. And then when you suture the skin between the skin and the trachea for making the tracheostoma, so we have to be careful for the release of tension. The tension is very important for the between the skin and trachea.
Okay, so let's just move on to the next step, that is the transvalvular entry. Here, the median glossoepiglottic fold is cut to expose the epiglottis in the valvula. The transvalvular entry is made from the contralateral side of the disease so as to actually
ensure that there are adequate margins from the beginning onwards. Also, one caution one needs to exercise is avoid insinuating inadvertent violation of the preepiglottic space that we saw in the last slide. Moving on to the laryngeal cuts, they're preferably taken from the head end of the table, but it depends on the surgeon's preference. Proceed again from the contralateral side of the disease, open the larynx like a book so that it brings the tumor completely under vision. Also follow the principle of mucosa first, followed by overlying soft tissue. Coming on, further progressing on to delivery of the specimen, once the larynx is by and large skeletonized, the post-cricoid cut is made with a sharp dissection of the mucosa and the submucosa over the cricoid, after ensuring a wide margin around the tumor. At this point, the specimen by and large is suspended by the attachment between the anterior wall of the cricopharynx and the posterior wall of the trachea. Constant traction and counter traction exposes this particular plane. And finally, this plane is excised and the specimen is delivered. Richa, any comment from your side till now?
So only two quick comments I'll make. That's very well put that we have to be oncologically safe and excise the mucosa followed by the submucosa. Now here I would suggest that everyone who is operating, the thing to keep in mind is that unsupported mucosa is not good for closure. It may end up with leak. So when we are taking the soft tissue cut, it should be at the level of the mucosa, so precisely the same level, so not ending up with the unsupported mucosa. That was one point. And second thing is that when we apply the traction and counter traction and we are trying to excise the specimen to take it out of the body, it's very, very important to identify the correct plane between the esophagus and the trachea. So going too close to the trachea and tampering with the trachealis muscle may compromise the oncologic clearance. On the other hand, going too deep on the esophageal side and taking out the esophageal mucosa may end up with the esophageal vascularity and necrosis. So there is a plane which is relatively avascular, and if we are in the right plane, that's what we have to identify while excising the specimen.
Any additions to that, Paisa?
My only point is towards the laryngeal entry, and I think more focus should be on that. Many times you may have a lesion which is coming on to the pharyngoepiglottic fold or the vallecula. And the point that you made needs to be reiterated that if you have a supraglottic extension, you need to enter the larynx from the contralateral vallecula. You need to also see that you do not have a lot of redundant mucosa which is not supported, like Richa said. And you need to ensure that you preserve lower down as much mucosa as possible. What transpires is as we take the cuts down onto the piriform, many surgeons I have seen go vertical rather than horizontal. So we need to focus on not stretching the larynx because it can cut the mucosa or shred the mucosa. And as you come towards the post-cricoid mucosa, you need to turn your make your cuts horizontal at the post-cricoid rather than vertical. That may help you save a lot of tissue, which is vital and which is usually very supported. And when you enter between the postcricoid and the trachea, there is usually a nice avascular plane. So try and get into that, which is lying dorsal to your cricoarytenoid and interarytenoid muscles, and preserve normal mucosa. That's all.
Any other comments from Dr. Yashimoto?
When you cut the preform sinus membranes, I always recommend the patient, young doctor to not to save the preserve the membrane too much, because the too much pierced membrane is a little bit thin, and so that's not good for the suture. And also the close to the if you like to save the more membrane on preform sinus, so you close to the paraglottic space, I think it's very dangerous for the tumor. So that's why I always recommend not to close, not to preserve the preform sinus too much. So you cut enough the preform sinus membrane. I think is
postcoital area is very important for the closing the membrane, but the film silence is not more wider, much wider, so that you don't have to care the fistula. That's all.
I think that's a very important comment.
So, Dr. Chavan, any more additions, or shall we move ahead?
Yeah, you just, when you do stoma, if you get into the tracheoesophageal plane and lift it up a bit more, then when you are going to cut the post-cricoid cuts or PFS cuts, the larynx, instead of getting anteriorly up, it gets lifted up horizontally. And you can very well see that mucosa being quite a loose there. It is a potential space. So you get up, you will end up preserving more mucosa in this method. So as a routine, you lift up the tracheal rings lower down once you have done the stoma.
So very important points by all the panelists with regards.
Just one more comment. What happens is that a lot of traction is generated when you are trying to get one finger into the esophageal junction and one in the trachea and try to get that plane. Many times it devascularizes the remnant pharynx from the prevertebral. So the resident should understand that the prevertebral blood supply is very critical to the remnant pharynx. And you should not get into that space, and you should not have the pharynx freed up from the prevertebral junction. So when you're doing that, please do not give so much traction that your entire pharynx is also elevated from the prevertebral.
So very important points with respect to maintaining oncological safety, removing with a good clearance, and also maintain viable tissue in the operative bed. So moving on, once the specimen is delivered, we move on to exteriorization of the airway by fashioning the stoma. Now, like Paisar spoke a couple of slides back, that the stoma size should be big enough for care, but it should be small enough for occlusion to ensure that there is no air leak. It should preferably be D-shaped. It should be sutured by non-absorbable interrupted sutures such that the cartilage cut end is not exposed. Next, we prepare the operated bed for voice rehabilitation. But
Another comment, I'm sorry. See, we spoke about the adult male trachea, and most of us will be dealing with in male laryngectomies. Uncommonly, we will come across a female laryngectomy, and in them, the trachea is usually smaller in diameter. So I would urge everybody to actually visualize that trachea and see is it adequate for maintenance of the stoma and with the prosthesis. So at that point, you should consider doing a tracheoplasty on table. So what I prefer to do is to then make two lateral cuts on the trachea for 1 or 2 rings and insert the adjacent skin so that you have a wider stoma, which will then cicatrize to be a circular wide stoma. Later on, doing the tracheoplasty in a post-laryngectomy is a slightly difficult situation because all the soft tissue like the internal jugular veins and all will get drawn in the cicatrization.
Perfect. In preparation for voice rehabilitation, we optimize occlusion of the stoma for maximizing the lung capacity which is utilized. First, by the design of stoma, like all the panelists and especially Paisar explained how to optimize the size of the stoma. Secondly is to prevent vertical slit stenosis, typically formed by a fibrosed sternocleidomastoid muscle. And that is achieved by releasing the sternal head of the sternocleidomastoid muscle such that the fibrosternocleidomastoid does not jut out and the occlusion of the stoma becomes easier and there is no air leak. The second way to prepare the operative bed for voice rehabilitation is maintaining the tone of the vibrating pharyngoesophageal segment. Now, the upper esophageal sphincter, it comprises of the inferior constrictors and the upper cervical esophagus. It helps in maintaining tone and prevents aspiration. So after a total laryngectomy, the trachea and the esophagus become 2 independent units with no risk of aspiration. However, also the upper esophageal sphincter now becomes a pharyngoesophageal segment with a change in its role from preventing aspiration to maintaining tone of speech.
The inherent tone of the upper esophageal sphincter produces a hypertonic segment. So how do we overcome it? By two procedures. One, and the most commonly followed, is a cricopharyngeal myotomy. It is performed on the cricopharynx till the level of the stoma. A lateral myotomy is preferred over a central myotomy, and gentle vertical strokes are made on the skeletal muscle and are continued till the mucosa bulges. The other technique of achieving a good tone is by doing a pharyngeal neurectomy. Now, this pharyngeal plexus is formed predominantly by the vagus and also by the glossopharyngeal and pharyngeal branch of the superior cervical ganglion. In hypopharyngeal cancers, the kind of cancer probably we saw in the case presentation a few minutes back, excision of a significant part of the pharynx would result into inadvertent neurectomy. And in such patients, additional myotomy may result in a hypotonic speech, which we want to avoid. So typically in such patients, we would not go ahead with a myotomy and stop at a inadvertent neurectomy, which occurs at the time of excision of the primary. Any comments? I would like to have comments from the panelists on this. Faisal?
Dr. Yoshimoto, any comments?
I think it's we always cut the cricopharyngeal muscle myotomy for the protecting from the too much pressure to the pharynx. So I don't know the neurotomy to better or the myotomy better. So I'm not sure. But in Japan, so always the patient is usually they have the problem of the too much tension for the shunt voice, making a shunt voice. So that's why we always to the myotomy first. That's all.
Pushottam?
In hypopharynx, usually our cut goes up to the piriform sinus apex. So your constrictor is already been cut. So it doesn't appear tight. So the myotomy is usually needed for all endolaryngeal cases. And hypopharynx, I don't want to give another mucosal cut because already your mucosa has been gone down. So there you can just concentrate on getting adequate closure, and that will decide whether you are going to put a TEP or not.
Any additions to that, Richa?
None. I think all covered. I mean, the main rationale behind doing whether the pharyngeal neurectomy or the cricomyotomy is that we don't want to end up with a hypertonic segment when they go for the phonation later on with the TEP, and both should not be done together. And the only thing is that you can very easily slide in the finger apart from just looking at the muscles, which are longitudinal and circular. Once you excise them, you can see the vessels prolapsing, so no going beyond. And you can feel it with the finger as well, like you will feel a kind of a release. So once you have given those cuts, you can appreciate it that way. So that's the only thing I want to say.
So let's then move on to the next step of tracheoesophageal speech. As of today, it offers the best voice outcome and must be offered to all patients unless contraindicated. I apologize for the overexposed photographs, but I guess I can make the points clear from my talk that one needs to achieve a controlled tracheoesophageal fistula with a pharyngeal protector, which is shown in the first picture, which is inserted into the remnant pharynx. And with the help of a trocar, a controlled tracheoesophageal fistula is created about 8 millimeters below the stoma. With serial dilatation and railroading method, the prosthesis is finally inserted and insinuated and released, and it comes out through the party wall. Any comments on this? Any preference on a particular method of performing a tracheoesophageal fistula or a tracheoesophageal prosthesis? Professor Yoshimoto?
Especially, I don't know that some comment, but we always use 12.5 millimeter the processors first, and we always do the prosthesis at the same time at the operation. For the
primary teeth fistula.
Yes, primary. Yes, that's
absolutely. Sir, any additional comments?
No, I just think that you need to see that your posterior membranous wall is properly matured. so that you are placing the processes just between 5 to 8 millimeters from the edge. Many times we tend to find that it's put too lower down, and then maintenance for the patient becomes a problem.
Absolutely.
So please do not, please see where your stoma is going to lie finally, and then place that puncture carefully. That's all.
Then moving on to the formation of neopharynx, I think much of it has been covered in the comments of the panelists, but I'll just touch upon each point. Primary closure is feasible when the unstretched width of the mucosa is at least 3 centimeters, or at least it should be easily possible to approximate the pharyngeal wall over the Ryle's tube. If that's not possible, then a patch pharyngoplasty is required, and it is augmented with a flap of pedicled or a free flap. So type of closure, there are various methods and types of closure which have been described. The pharynx can be approximated in a horizontal fashion, where the base of tongue is approximated to the cricopharynx in a horizontal suture line. It could be in a vertical fashion. It could also be in a T-shaped manner. There has been a lot of literature. However, there is no clear-cut evidence to prove one in favor of the other. By and large, but the consensus is that the T-shaped closures involve a tri-pointer and could be avoided. However, it totally depends on individual surgeon preference and experience on the type of closure. Similarly, the type of closure would vary with respect to the suture material and the type of sutures which are taken. Like the suture material could be a vicryl, a silk, a PDS, or even staplers. Type of sutures which one may follow would be either intermittent, interlocking, or continuous sutures. Again, there has been no significant difference in the occurrence of pharyngocutaneous fistula rate in one over the other. But the consensus is, of course, there has to be at least a 2-layered closure, mucosa and submucosa as the first layer, and the remnant muscle as a second layer. Cornels, inverted stitches are what are preferred. Buttressing the suture line with a vascularized flap, example, pectoralis major muscle, particularly in case of salvage laryngectomy, is being explored by a multicentric randomized controlled trial, and hopefully we should get a clear-cut evidence in favor or against it. Any comments from the panelists with respect to personal preference, choice, justification? Dr. Yashimoto? I would prefer the three-point. I prefer the T-shaped suture, because the releasing the tension is very important, more important than the 3-point. So that's why so we don't like the horizontal and the vertical. So we like to the T-shaped suture. Paisa? So I would look at what is the site of the lesion. If it is in the pyriform sinus, very rarely do we get a horizontal closure, because you have resected quite a bit of the pharyngeal mucosa. In those cases, we will end up with a vertical closure. So also is in a supraglottic cancer, when you have resected a significant part of your lateral pharyngeal wall superiorly. In an endolaryngeal disease, it is very comfortable to do an horizontal closure. And in those cases, it is very suitable and advisable to do a horizontal closure. So that brings into focus the way you actually resect your larynx. So all the steps that Mitali had shown thus far are very critical, that we actually preserve uninvolved tissue so that we can go towards a proper closure. So for an endolaryngeal disease, if you sacrifice too much of your lateral pharyngeal wall, the pyriform sinus, and your cuts are too far superior into the base tongue, you will not have a very stable horizontal closure. So focus on where is the disease, plan your resections carefully, do not compromise on oncologic safety. The type of suture material doesn't matter. A meticulous, non-strangulating suturing is very critical. Like Richa said, rightly, do not have unsupported mucosa. See to it that you separate out all the uninvolved mucosa prior to closure. And of course, we will measure the pharyngeal remnant, see whether there is any turgidity of tissue
whether it's not really getting approximated well. Post-radiation, do not really close these pharynges just because it is reaching 3 centimeters. See how they are pliant, and then try and take a call whether augmentation of the pharynx would be more suitable in those patients.
Dr. Chavan, any
apart from what pies are covered, I use 2-0 for base tongue to pharynx stitches, and I prefer T-shaped closure for most of the non-endolaryngeal cases. And I try to take U-shaped stitches, which will start from above and come back, cover the other side and go up, and the reverse the same way from down. So it looks like an interlocking stitch. That way, the trifurcation point can be taken care.
Richa, for the benefit of students, could you give us in a nutshell, tips on how to plan or an algorithm for planning pharyngeal closure with respect to advantages of a horizontal versus a vertical closure and a T-shaped closure?
Okay, as the discussion has, it has covered all the points. The first and the foremost thing that we need to keep in mind is that when we are doing a closure, look at the adequacy of the mucosa. So I think the first principle will be no extra tension or drag on the suture line. If it is an endolaryngeal lesion and we have adequate mucosa preserved in the piriform sinuses, probably the transfer closure may be a good option because then you don't have a pseudovertical formation and it has a wide conduit and the chances of stricture are lesser. But in case you have already compromised the mucosa, go ahead and you can go ahead with the T-shaped closure or the vertical closure. Again, before you decide the closure, don't be hell-bent on that I want 3 centimeters, so it should be a primary closure. Look at the quality of the mucosa, whether it is post-radiation, non-compliant, failed mucosa. You may be a little liberal in putting in a patch in those cases, then thinking about just a primary closure because it is 2.5 centimeter or 2.7 centimeter, where you is a wide the concept is data says that laryngectomy, the hospital say is to the only PMMF or not that we
the new violating the carotid sheath. Any comments on this? Does every one of you follow this step, or are there any special circumstances where one would follow this step? Professor Yashimoto, do you follow this step routinely?
I don't follow so I don't I have not been imagined this specs and but that's a very good choice, I think.
Dr. Chavan, do you follow this step routinely or?
No, not routinely. Yeah.
Sir, any particular tips on compartmentalization?
I think you need to actually focus on what you meant by compartmentalization. And I think what Mitali means is to isolate the pharyngeal compartment from the lateral neck compartment. And towards that, most of the times we divide the sternal head of the sternocleidomastoid. And that releases the sternomastoid adequately for us to suture it between the carotid and the prevertebral space. So that in effect will isolate the entire pharyngeal compartment from the lateral compartment. And usually in post-radiation cases or in cases where there is a large pharyngeal defect and you have closed primarily, in those patients I would consider this compartmentalization because the chances of leak are higher in these patients. Going by literature, the per primum patients whom we have operated, the leak rates are between 8 to 17%. And in the ones that are salvaged following radiation and concurrent chemoradiation, it's upwards of 30 to 40%. So in a per primer patient, you will compartmentalize only if you have a large pharyngeal tumor.
Typically in a laryngectomy patient, you want locoregional control, you want no nasogastric tube dependence, and you want good voice outcomes. So I'll end my talk by this 3-second slide, which shows what an ideal patient should be. Translated as, I have no problems after surgery. That should be our ultimate aim. Thank you so much. And thank you, panelists. And I would like to have closing comments or tips or pearls with related to the total laryngectomy surgery from each one of you. Professor Yoshimoto, sorry.
Oh, thank you very much. I really enjoyed, and it was very nice discussion. Thank you.
Very well presented. I think it brought out all the points that are required to do a very good laryngectomy. And the focus should be the patient's end point, that the patient should be able to eat and swallow normally and speak with a good alaryngeal mechanism. Thank you.
Dr. Purushottam, any closing comments?
Yeah, nicely covered, Dr. Mitali. There was nothing for us to cover, but as we are formalized to put the points we were putting. So otherwise, technically, it was a flawless presentation. Thank you.
Richa, any closing comments, any tips or anything for the students to take home? Message for the students to take home?
Dr. Mitali, it was very, very comprehensively covered for the surgery. Just a thing I want to add for the students that in addition to the surgery, look a little before and look a little after. So I think when you're planning the patient for laryngectomy, get a speech following evaluation so that they know what they have to expect and what they have to deal with, and be liberal with these sessions in the post-operative setting as well. So if you have done the TP, they pick up the voicing quickly. But surgically, an excellent presentation, Dr. Mitali.
Thank you so much. Thank you for the valuable contribution to each and every panelist. Thank you. Poonam, over to you.
Thank you, Dr. Mitali Dandekar, for making this complex topic easy for us to understand. And I thank our experts, Dr. Prathamesh Pai, Dr. Purushottam Chavan, and Dr. Richa Vesh, and Dr. Shaiji Yoshimoto for highlighting the important points on this topic. Now coming to the end of this session, I would welcome Dr. Poonam ma'am to conclude this program.